Minash-Shaytanir-Rajim. Bismillahir-Rahmanir-Rahim. I welcome you all to the Pakistan Society for Rheumatology Silver Jubilee Annual Conference. And today is our first pre-conference workshop, second PSR Pediatric Rheumatology Review course in collaboration with APLAR Pediatric Rheumatology Special Interest Group, and it's endorsed by APLAR Academy. I'll start the session with recitation of the Holy Quran. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم قل هو الله أحد الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد Sadaqallahul Azim. Now I'll request all of you to please rise from your chairs for the national anthem. Thank you so much. You can sit on your chairs. Thank you. I also welcome the people who have joined us on the Zoom link. Now I would request Professor Dr. Sumaira Farman Raja to come to the podium. She is professor and head department of rheumatology at National Hospital and Medical Center Lahore. She is a visiting faculty and chair pediatric rheumatology at Institute of Rheumatic Disease, Central Park Medical College. She's also adjunct faculty of Fatima Jinnah Medical University, Lahore. She's a director and consultant rheumatologist at Arthritis Care Center. She's also founder, trustee, and co-chairperson at Arthritis Care Foundation. And she's also the convener of this course endorsed by APLAR. Over to Professor Sumaira.
Thank you, Bilal. Assalamu alaikum and good day to all of you. I think we're already running a little behind time, so I am going to start first with thanks to our very senior pediatric colleagues who have honored us with, being a part of this course. And we would like to welcome our chief guest, Professor S.N. Wahid Rathore, who is the VC of University of Health Sciences, and Professor Masood Sadiq, who's the VC of University of Child Health Sciences, to please inaugurate the course by cutting the ribbon. We will also request the guests of honor, Professor Tahir Masood, Professor of Pediatrics and Principal of Rashid Latif Medical College, Dr. Aisha Numan, CEO Shalimar Hospital, and Professor Sajid Maqbool, who has been my teacher and who set up the pediatric department both at Sheikh Zayed and Children's Hospital. Maybe?
Thank you.
I'll also request Nighat to join them.
And Dr. Aisha Numan. I'll also request Dr. Aisha Numan to come. Dr. Aisha Numan. I'll also request Dr. Laura Lewandowski to come for the Thank you. Thank you. Now I'll request our chief guest to please come on the stage and have your seats. Professor S.N. Wahid Rathore and Professor Masood Sadiq.
Professor G, also our guests of honor, Professor Tahir Masood, Dr. Aisha, Professor Sajid Maqbool, Dr. Aisha Numan, Professor Rashid Ayub. Professor Rashid Ayub is heading the department in Fatah Memorial, and it's a real honor. We're getting another chair. Aisha, aap aao na, please. We have two chairs. We have two chairs. Yeah. Bismillah ar-Rahman ar-Rahim. Without further ado, I'm going to talk about our children who suffer from disability due to musculoskeletal disorders. I'm primarily an adult rheumatologist with special interest in secondary training in pediatric rheumatology. These are my evidence-based references. I dedicate this to all children with rheumatic diseases who suffer disability due to delayed diagnosis and treatment. The outline of my presentation is talking about the pediatric rheumatology workforce issues, the importance of treading new pathways for access to quality learning for allied health professionals, and possible solutions. We know that there are around 6 to 7 million children worldwide affected with rheumatic diseases, of whom more than 50% live in Asia. It remains a leading cause of acquired disability in Asia Pacific. Even in the United States and United Kingdom, almost 1 in 1,000 have some form of inflammatory rheumatic disease. We have no data from Pakistan. What happens to children who don't get treated? So without treatment, on the left, this beautiful girl is disabled for life because she came too late. But with treatment on the right, you can see, you catch them within a few months. And with just a simple drug like methotrexate, which is cost effective, they can have an absolutely normal life. What are the prevalence rates of JI? They vary globally, but in Pakistan, we have no data. If we look at our Pakistani population, we have an estimated pediatric population of about 100 million, and the prevalence may be as high as 2 million children. What is the ideal acceptable requirement for pediatric rheumatologists? That is 1 for every 500,000 children. Minimum acceptable is 1 for every 250,000. And the current international pediatric rheumatology workforce is just 12% of this, with 40% based in the United States. So actually in Asia, approximately we just have 1 pediatric rheumatologist for every 26 million children. We know that improved outcomes require improved access to care, and looking at this, these two publications, we see that even in the United States, which has the maximum amount of pediatric rheumatology, a lot of internist rheumatologists act as substitutes for them in many regions that don't have pediatric rheumatologists. And there is a projected demand that at the moment, probably they're 33% short of what is required, but by 2030, they will have 100% shortfall. When we look at the disparity between the world's children, and you can see that the world's children, as the colors go up, this is increased density of children in the population. This area, and compare it to the world's pediatric rheumatologists, and you can see Pakistan is among the top young population countries, and we hardly have any pediatric rheumatologists. So just very briefly, just to tell you that for Pakistan, shown here, we fall in the lowest GDP. We fall in the lowest with countries with critical shortage of health professionals. We fall in the lowest bar of health expenditure as percentage of GDP. So We are stuck with low GDP, high percentage of young population, least public health spending, and the most shortage of pediatric rheumatologists. And these constraints then compound across Asia-Pacific developing countries of limited resources, insufficient structured training, and handful of trained pediatric rheumatologists. And care is generally delivered by adult rheumatologists, pediatricians, general physicians, and sometimes orthopedics. When we look at the survey, you can see that even in developed countries like Australia and New Zealand, there is still a proportion of children being seen by what you call, health professionals with special interest in pediatric rheumatologists. In Pakistan, most of us would fall in that category. Even in India, a large proportion are those. So what can we do? There's a concept that I really love, and that is of hybrid training and surrogacy in pediatric rheumatology. If you don't have anything, you have to start somewhere. And I myself have been a product of hybrid training and surrogacy, because I was very lucky in my mentors, Professor Nighat Mir, Professor Sarah Walker, through whom I was awarded the International Fellowship by American College of Physicians. And I went to KUMC and trained with Professor Carol Lindsley and got the opportunity to meet Professor Cassidy, who's the father of pediatric rheumatology in the US. And then through a year-long course, which was online with the interactive course with the University of Western Australia, run by Professor Prudence Manners, seen here. So at that time, when we looked at the pediatric population in Pakistan, the ideal requirement is 800, minimum is about 400. And the time when I went and I did this training, there were only about 15 pediatric rheumatologists who were adult with some special interest, some kind of clinical training, some kind of online courses. In addition to some pediatricians, and particularly in Children's Hospital, Professor Tahir Masood, I must mention, who actually started the Department of Pediatric Rheumatology in Children's Hospital, when I don't think any other pediatric hospital had that. So after that, all these trainees that, about 16 trainees, plus 5, and now we have 7. So that's almost 22 plus trainees who trained in our department, got interactive, focused pediatric rheumatology exposure as well. And I think that now we can say that we have about 37 up from 15 adult pediatric rheumatologists with special interest in children. And they have gone, these are all our children, actually. Some of them are not here, but as you can see, the wonderful thing is that we've now got rheumatologists with some pediatric rheumatology training in remote areas, which are adjoining Afghanistan. In Quetta, in Balochistan, we have somebody who's under training and is going to go back to FATA, and then also, in south of Punjab, as well as in areas in KPK. And I, in my department, all of us are very proud of this. I just wanted to share this. I couldn't find a photograph. So this was the Children's Hospital Pediatric Rheumatology Symposium in August 2018. And I think that was the first effort by anybody, at least in Punjab, that I know, to try and project pediatric rheumatology here. And Professor Tahir Masood was very kind and invited myself and Nighat and our faculty to present there. Followed by, this was the first PSR pediatric rheumatology course that we ran. And it was very well attended by PSR members as well as trainees. So collaboration within specialties, nationally, provincially, internationally, everything works. And so we have a global task force, and I'm a member of the steering committee. And all of these across the globe, we are trying to work together and develop an APLAR pediatric rheumatology course, as well as APLAR guidelines on treatment of JIA for low resource income countries. This is a pediatric rheumatology special interest group team. I couldn't get all the photographs, but I have to thank them, because without their support, nothing is possible for anybody who's trying to do anything. Teamwork is very important. How else can we, have we tried to improve access to care and increase workforce capacity? We know that, patients in Pakistan first go to either a GP, an orthopedic, adult rheumatologist. So, we thought of trying to empower family physicians, and this was an ILR-funded course that Saira ran, and we were on the faculty, Nighat, myself, and Ahmed. And we had, people, the general practitioners from remote areas in Pakistan who had no rheumatology service at all. We had excellent feedback, and based on that, published this article, which was suggesting a rheumatology curriculum for empowering family physicians in Pakistan. Professor Nighat is the course director of this primary care rheumatic and musculoskeletal medicine PG certificate course, and in which I am also a faculty that is going to be dealing with the 2 modules on pediatric rheumatology. This is the course that we're running right now. I wanted to just mention that the APLA Pediatric Rheumatology SIG has successfully completed 2 years of every 3 to 4 months webinar series, which is 60 to 90 minute webinar based on cases and a very hands-on interactive discussion. As well as we ran an autoinflammatory certificate course as well with the University of Tehran. So does this work? I mean, do these online sessions have any impact? Yes, they do. So you see on the left, there's this child who just did not get picked up for vasculitis. He had gangrene, he had one limb that was amputated, that the other, by the time he came to us, all we could do was halt it further, but obviously we could not save him. And this is an approximation. The child who came, didn't have a picture, but there's another one who actually got referred in time. And you can see that, we were able to salvage her with a treatment in time. So in summary, what can we do for the rheumatology workforce? What are the solutions? We must increase workforce capacity. We must invest in training, and I'm proud that I'm part of the Arthritis Care Foundation, which has floated scholarships, out of which, as I said, 16 were fully funded, and I think 3 or 4 partially funded, and we still have our trainees that are being funded by ACF. We must combine rheumatology pediatric care and training programs, obviously regular CMEs, particularly with family physicians. The importance of treading new pathways, out-of-box solutions. So, one of those is the APLA Peds Room 6 webinars, and then hopefully the BMJ MSK online course that is going to be run. Lastly, working together nationally, working together internationally, and now we have collaboration with ACR PRISM, with the Global Musculoskeletal Task Force, with PRESS and BSR. This is Arthritis Care Foundation Clinic, some of the children that we have been able to treat and privileged to help them improve their lives. And this is a card that was actually made by her, and she has been on biologics and as well as this boy, completely ACF funded. So our children are our world. I don't think we have any 2 doubts about that, all of us. But we must make the world a better place for them by opening our hearts out, by working together, by opening our minds and thinking of innovative ways. Just wanted, this is Laura. Thank you, Laura, for coming all the way from NIH, US. And she's an integral part of the course today. This is a little child that I met after 3-4 years who was lost to our follow-up. And I'm so sad. She was like this when she came. And look at her. She has stunted growth. She was doing so well, but then we lost her to, she's really not doing well. And probably got pericardial disease and myocardial involvement now. Or some of the walks in public awareness that we have and our department has been doing. This is a combined APLAR and musculoskeletal task force meeting in Brisbane, and this is our core team. I'm very proud of being a part of this team. So these are the resource links, especially if you go on PMM online, you will see PGALs and everything. These are great, excellent resources. Lastly, please let's not forget, we have to stop global warming. And there's no planet B, and this is our country, and it's going to spread, and it's so sad that we have only contributed a minuscule amount to the problem, but our people are suffering. So we need to work together on all issues. Thank you so much for your attention. I'm now going to request Dr. Mariam and Dr. Rafaqat to moderate the session, and we're going to start the online course now. Thank you.
Thank you so much, Madam. So I'm Dr. Mariam Amir. I'm Senior Registrar Rheumatology in Institute of Rheumatic Disease, Central Park Medical College and Teaching Hospital, Lahore. So I'm going to start our session 1. So our chair is Professor Dr. Nigat Mir. So she is Professor and Associate Dean, Institute of Rheumatic Disease, Central Park Hospital. She is Chair Department of Rheumatology, National Hospital and Medical Center. She is Director and Consultant Rheumatologist, Arthritis Care Center. She is Chair Rheumatology Faculty, University of Health Sciences. Okay, sorry. So, and she's also Adjunct Faculty, Fatma Jinnah Medical University, Chair and Founder Trustee, Arthritis Care Foundation. Okay, so our panelists, as we introduced before, these are Professor Harun Hamid, Professor Tayyeba Khawarbat, Professor Shahid, Professor Aisha Arif, Professor Waqar Hussain, Professor Fakhr. Okay, and I'm the moderator. Okay, so let's start our first talk. Our first presenter is Dr. Laura Lewandowski. She is, so next slide, please. So she is Assistant Clinical Investigator and Head of Lupus Genomics and Global Health Disparities Unit. She's from Maryland, NIH, USA. I welcome Dr. Laura Lewandowski, please. So she's going to talk about childhood onset lupus, a unique population. Thank you. I request these panelists to come on stage, please. Thank you.
I think chair is Nikhat and Professor Tajwar is the co-chair. Do you want to sit there? Yeah, because you'll be able to see better. Okay.
Good morning, everyone. I'm delighted to be here with you on this pediatric rheumatology review course, and I'll be talking to you this morning about childhood onset SLE, a subject near and dear to my heart. I'm Dr. Laura Lewandowski. I'm an assistant clinical investigator at the NIH, and it's a pleasure to be here with you in Lahore. This is my disclosures slide. I have nothing to disclose, and all the views that I present today are my own and do not reflect those of the NIH. So the goals of this talk will be to review the diagnostic criteria of pediatric and adolescent onset lupus, discuss the epidemiology, review differences in disease onset and severity between childhood and adult onset lupus, and discuss prognosis. I won't go too much into management because that will be a later talk. So as many of you know, systemic lupus is a chronic multisystemic autoimmune disease that currently has no cure. The exact cause is unknown, but it's thought to be a combination of a genetic susceptible host that encounters an environmental hit that kind of triggers autoimmunity. And then that loss of immune tolerance leads to systemic autoimmune-driven inflammation that can affect any part of the body, and it can cause damage if left untreated. So there's a few different classification criteria. There's some historic classification criteria, such as the ACR criteria, the revised 1997 ACR criteria. That's kind of fading out from use as we have new criteria coming along. And then there's other classification criteria. And these have been developed because lupus is really a syndrome, so there's no one clincher diagnostic test. It's a combination of laboratory values and a clinical examination and history that leads us to the diagnosis of lupus. And so we try to capture everybody that has lupus, but not miss anybody, and also not misclassify. I will have to say, I always like to remind people that these are classification criteria to enter somebody into a research study. And so they're not diagnostic criteria, although we often use them that way. So sometimes patients will have a lot of symptoms, but they don't quite meet the classification criteria, and we call them incomplete lupus or we diagnose them, and I'll kind of go through some of the limitations of these criteria as I go on. So out of all of these, the 2012 SLIC criteria have been found to be the most robust in pediatric populations globally. So they've been validated in multiple cohorts in high-income and low-income settings, and this is the most robust that we have at the moment. And so it requires 4 criteria, at least one in the clinical and 1 laboratory criteria. And I'm not gonna kind of read through all of these things on the slide because there's many, but you can see it's some of the things that we think of with lupus. So the immunologic criteria, such as a positive anti-nuclear antibody of high titer, an anti-double-stranded DNA, and anti-Smith, and then some clinical criteria, such as the classic skin rashes, oral nasal ulcers, non-scarring alopecia, arthritis, and so on. And then the ACR-EULAR criteria is another one. This can be a challenge in low-income settings depending on your access to laboratory testing. So some places just can't consistently get an ANA, and you can see to even enter into the algorithm of this diagnostic criteria, you have to have a positive ANA at a high titer. So this is another one that is used, but in really resource-limited settings can be restricted. And then the 1997 criteria was used for a long time. You needed 4 out of 11 of the following criteria, but that as these newer criteria are coming along, it's more for historical cohorts and is being more phased out in active research. So the epidemiology of lupus can really vary depending on the area, and so it, depending on the local population and the gender distribution, can be as low as 0.8 and as high as 12.4 per 100,000 persons, and the prevalence the same. And in North America, where I worked, incidence rates are higher in Hispanics, Blacks, Native Americans, and people from Southeast and South Asia. Dr. Farman already showed this slide, but I just want to highlight that we don't fully understand the burden of pediatric onset lupus in the world because the places where the most of the children live have the fewest pediatric rheumatologists. So I think we need to kind of continue to build up the workforce to really understand the world's burden of pediatric onset lupus. So lupus in childhood, about 1 out of every 5 lupus patients has disease onset prior to age 18. So 20% of all of our patients will have disease onset in childhood. Presentation before age 2 is rare, and the inclusion criteria to be included in childhood onset lupus really depends on the site of the study because people transition child care to adult care at different rates in different settings. So sometimes some places do it at 13, some at 16, some at 18, and so the study kind of is location dependent. So how is childhood onset lupus different from adult onset lupus? The thing you really want to drive home from this talk is that it's worse. So it's earlier onset, it's more severe, it requires more therapy, despite children being younger, having healthier bodies, taking less medications. There's higher disease activity as measured by the disease index that we call the SLEDAI, and there's more damage, again, despite younger, healthier bodies that we measure by the SLIC damage index. They present more acutely, they present more severely, they have more active disease throughout the course, and the mortality is twice that of adult onset patients. And mortality is actually something that's a little tricky to measure because in childhood onset patients, we usually follow them robustly in research studies until they turn 18. And they go off into the ether and get included in adult studies, and it's hard to follow them through the course of their lifetime. So we actually have a difficult time assessing actual childhood mortality, except in a few small studies that were able to track patients for a really, really long time. But from what we do know, the mortality is greater. And then you'll see through my talk, there's some clinical differences with more leukopenia and more hemolytic anemia. So the gender balance is different in children as well, and it's really striking prepubertal versus postpubertal. So we always think of lupus as a really big predominance in women. So in childbearing age, that's absolutely true, 9 to 1, women to men. But in patients younger than 10, it's more balanced, so about a 4 to 3 gender ratio. Okay, so some clinical features of childhood onset lupus. Lupus nephritis, which is a glomerulonephritis and inflammation of the kidneys, and is often one of the most severe manifestations of this disease. Your clinical signs will be microscopic hematuria, proteinuria, hypertension, and edema. I do want to emphasize that lupus nephritis can also be clinically silent. So if you're suspecting lupus in a patient, it's important to do a urine study. And the prevalence of lupus nephritis in children is more prevalent than in adults. So depending on the study, anywhere from 32 to 75% compared to 34 to 48% of adults. There's 6 classes of lupus nephritis, and I'm just showing them here. I'm not going to read through this entire slide, but classically, class 3 and 4 are kind of the active inflammatory states that we think about. Class 5 is more membranous, so it gives you more of a proteinuria, and class 6 is a scarred kidney, so the inflammation was there, it's done its damage, you won't recover that kidney tissue. So in childhood onset lupus studies that we have, the vast majority of children have really inflammatory lesions, so they don't have the mild class 1 and class 2. Most of them have class 3 and class 4, the vast majority of them. So if you have a patient with lupus and you do urine studies on the initial test, they don't have hypertension, they don't have proteinuria, they don't have hematuria, and you're trying to counsel the family, how likelihood will kidneys be involved? Well, if you are following them for the first beginning of their disease, if they don't have lupus nephritis in the first 2 years, they're likely not to get it, because about more than 90% of all children with lupus nephritis will present in the first 2 years, and actually almost 80% of those will present in the first 1 year. So with children, because they have this more severe phenotype, if they will have lupus nephritis, it will be present in that first 1 to 2 years. 40% of them will have high blood pressure, hypertension. That's more common in males and in the US in Black patients. And proteinuria and CAS are more common than in adults. Okay, so neuropsychiatric lupus, moving on to kind of the brain and nervous system, is CNS involvement. In children can have a wide range of clinical presentations: seizures, psychosis, hemorrhagic or thrombotic stroke, chorea, headaches, a cognitive dysfunction, and mood disorders. And I have to say, a cognitive dysfunction in a child can show up as behavioral changes in the very young child and changes in school performance in an older child. Within 1 year of diagnosis, 70% of childhood onset lupus patients have features consistent with NPSLE. However, this is a wide range of symptoms, and the most common feature is actually headache. Psychosis is more common in children than adults. About 1 in 5 childhood onset lupus patients has psychosis. Visual hallucinations are a common feature of that manifestation. Seizures are just more common than kids in general than adults, and in lupus patients that's true as well. The CSF can be abnormal, but can also be normal with NPSLE. And imaging is abnormal in 11 to 70% of cases, which is such a wide range, it's almost not helpful, but you can see cerebral atrophy and white matter lesions. And there's some neurocognitive testing that you can do, but sometimes that's laborious and difficult to attain. Depression is a common mood disorder, and since this is also a disease that's very common in the adolescent population, it can be really tricky to kind of tease it out. Is this patient depressed because they are a teenager who's going through kind of adolescence? Are they depressed because they're an adolescent with a chronic disease? Or are they depressed because they have active lupus? It can be really tricky. And then cerebral vascular disease is more common in children. And then one particular kind of clot, a sinus venous thrombosis, is more common in children than adults, often with a positive lupus anticoagulant. So for the pulmonary system, pleuritis is the most common manifestation, and it's more common in children than adults. Restrictive lung diseases and decreased DLCO are often possible. Pulmonary hemorrhage is very rare, but it's a really important thing to recognize. If a patient has acute shortness of breath and is really severe, you want to think about it because it can really increase mortality. From the cardiovascular perspective, pericarditis is the most common cardiac feature. 15 to 30% of patients will present with inflammation around their heart. If it goes on for a long time, that inflammation and pericarditis can actually cause tamponade. And then symptomatic coronary artery disease and myocardial infarction are very much less common than in adults because they have younger, healthier hearts, and so their inflammation is just starting. However, it has been studied that they do have changes in their blood vessels. So the endothelial progenitor cells are responsible for vascular repair, and in CSLE, they're decreased in number and maturity. There's inflammation in the endothelium mediated by type 1 interferons, and there's dyslipidemia. So they're kind of set up for further cardiovascular problems later in life, and so you really have to monitor their cardiovascular health. Their hematologic system is very often involved in their lupus. So anemia of chronic disease is the most common feature that you'll see in lupus. You can also get a hemolytic anemia, and that's antibody mediated from the autoimmune disease, and they can have lymphopenia, so low lymphocyte levels that correspond with disease activity and their double-stranded DNA levels. Thrombocytopenia is very common, often associated with antiphospholipid antibodies and antiplatelet antibodies. HUS and TTP are rarely presenting features of SLE, of childhood onset SLE, but it's important to note that children get immune-mediated thrombocytopenia, and sometimes that's idiopathic, but 1 out of every 3 of those patients in the childhood onset lupus, or in the childhood populations that have been studied, go on to develop lupus. And if they have antibody-mediated platelet and red blood cell destruction, those rates go even higher. So if they have Evans syndrome, they're even more likely to go on in lupus. And this is really different than adults. I think the rates in adults are about 2 to 3%, but in children it's much higher. And then skin and mucocutaneous, they have malar rashes more often than adults. Discoid lesions actually less often than adults. Discoid is more common in adult populations. So the malar rash is that red butterfly rash over the cheeks that spares the nasolabial folds. And the discoid is a round lesion that will have active inflammation at the periphery and central atrophy. And they have alopecia that's diffuse and non-scarring because it's more likely to be inflammatory rather than discoid, and it reflects active disease. They often have oral and nasal ulcerations, and their oral ulcerations will be like pictured here, most often found on the hard palate, and they're most classically a painless lesion. So often you're examining the patient, you're getting the history, and you look in their mouth and you find that they have an oral lesion, and the patient is surprised because they never knew it was there because it doesn't hurt. Arthritis is common, and 80% of childhood onset lupus patients experience it. Frank arthritis with actual swelling and warmth of the joint is more common in children than in adults. The arthritis is often bland, so it's not very, very painful, and it is symmetric. And 90% of arthritis presents within 1 year of diagnosis. So like lupus nephritis, if they're going to have arthritis, they're probably going to have it in the first year. And an important thing to note, lupus patients are at risk for avascular necrosis, so a blood clot, a microclot that blocks the blood flow to the bone or joint. So if they have a new swelling after the first year of diagnosis, and it is painful, you really want to consider avascular necrosis, especially if they've been on a lot of steroids. And then further in endocrine and bone health, osteopenia is very common. They have lots of reasons for their osteopenia. They have inflammatory disease, which is not good for bone health. They use a lot of steroids. They stay out of the sun and use a lot of sunscreen, so their calcium and vitamin D levels are lower, and they sometimes are very sick, and they don't move around as much, and so they're not getting as much exercise and weight-bearing activity. It also occurs during adolescence, during the primary bone-building years. So they're really at risk for osteopenia and fractures. And so you want to monitor this supplement with calcium and vitamin D. And then autoimmune thyroid disorders are present in about 15 to 20%, same as adults. And for children, menarche in female children, menarche can be delayed by 1 year from a combination of things, the stress of the inflammatory disease and other things. An important consideration for childhood onset SLE is they're still a growing child. So the steroids can cause growth delay. That's usually on higher dose steroids that we give for induction therapy. As we wean those down, their growth usually catches up. Their peak bone mass is achieved in adolescence, so you want to keep bone health in mind. You want to keep up on their immunizations, and their school attendance and performance is really important during this time, and you want to keep them in school as much as possible and emphasize good health and nutrition. Treatment, I'm not going to go into because that's a whole nother talk at this session, but I'll just make the point that aggressive disease requires aggressive therapy. So their long-term diagnosis, they have severe disease, they accrue more damage, and have higher mortality rates than adults. The major causes of their mortality are renal disease, severe disease flares, and infection. The impact of systemic racism has been studied in the United States, so minoritized populations that have lower socioeconomic status and severe disease and non-adherence has been linked to worse outcomes. And adolescence, it's a time of rebellion, of independence, and patients often have issues with non-adherence because they're, trying to make sure that they can trust the adults in the room and trust themselves in figuring things out. And so you have to really monitor if they have a disease flare, is this because they're not taking their medicines. Overall, childhood onset SLE is a success story of survival. So when it was first discovered in the 1950s, the survival rate was 30% at 5 years. And then we discovered corticosteroids, and then we discovered other immunosuppressive medications. And the recent 5-year survival rate for childhood onset lupus has been reported to be as high as 95%, with 10-year survival rates at 86%. So that's a huge amount of progress in a short amount of time. However, we still have work yet to do because they're still at a 5-fold risk of mortality over the general population, and children have a higher risk even compared to adults. And not many diseases with adolescent onset have a 15% chance of death in 5 years. And so we really need to continue to work to do research and to both clinical and basic science to understand the drivers of this disease, to get early diagnosis, improve therapeutics, and management of comorbid conditions. So my take-home points are that childhood onset lupus is more severe and more aggressive than adult onset lupus. So you really need to watch these patients closely, monitor them carefully, and be aggressive in your disease management. And more information is needed globally to optimize the management for this population. Thank you.
Thank you, Laura, for such an elaborative talk about childhood lupus. And as you said, it's a very aggressive disease, and we need to be very vigilant in picking our children and to escalate our treatment. Thank you so much. So our next presenter is Dr. Sui Ping Tang. So she is senior consultant pediatrician. She's pediatric rheumatologist in Seliang Hospital, Malaysia. She's going to talk about managing childhood lupus, latest guidelines.
The SHARE initiative on managing childhood lupus. We all know that SLE is a severe, chronic, multi-system autoimmune disease, of which to thank the Pakistan Society of Rheumatology for inviting me to speak today. Today, I'll be sharing on the European evidence-based recommendations for the SHARE initiative on managing childhood lupus. We all know that SLE is a severe, chronic, multi-system autoimmune disease, of which only 15 to 20% have a childhood onset. Childhood onset SLE shares the same pathogenesis with adult onset SLE, but has a more severe phenotype. There is often higher disease activity with more major organ involvement, especially the kidneys and the brain, and in addition, there is higher disease burden and long-term damage, resulting in significant impact not only on growth, but also the development and psychology of the child. There are now good evidence-based recommendations for adult onset SLE, including this 2019 EULA recommendations, which I'm sure you are all familiar with. Unfortunately, such guidelines are still sorely lacking in children. Let's now look at the European evidence-based recommendations for diagnosis and treatment of childhood onset SLE. Lupus is actually considered a rare disease in Europe with a low prevalence. This in turn makes research fairly challenging, leading to a paucity of evidence-based data and subsequent guidelines for disease management. This often leads to considerable variation in clinical practice, not only amongst different countries or centers, but amongst different clinicians within the same center. This evidence-based recommendation is therefore an attempt to foster equity of access to higher standards of care and uniformity of practice. With regards to the diagnostic recommendations on a general level, firstly, there are currently no validated diagnostic criteria for child SLE, but based on current evidence on the SLIC criteria, which is mainly from adult data, the SLIC criteria can be used as classification criteria in childhood onset SLE. Number two, this SLIC criteria can also be used to help prompt referral to a specialist center to enable timely initiation of appropriate treatment. A referral to a pediatric rheumatologist is warranted even if the child does not fulfill classification criteria for SLE, as this is not a diagnostic criteria. And the suggested criteria for referral includes the presence of ANA positivity with two other criteria, which can be both clinical or one clinical and one immunological. Number three, when considering a diagnosis of SLE, apart from the anti-nuclear antibody, which is the hallmark autoantibody in SLE, the testing of extractable nuclear antigens are also strongly recommended. Number four, however, as there are no antibodies that have specific predictive qualities, for example, disease severity, organ involvement, and the age of onset, so patients who are negative for anti-double-stranded DNA antibodies and ENA can still be diagnosed with childhood onset SLE. Number five, hereditary complement deficiencies can be predisposed to lupus or lupus-like illness. Thus, it is important to consider these complement deficiencies and screen for them in the diagnostic workup, especially in younger children. However, do note that there are also other causes of monogenic lupus outside the complement pathway, thus normal complements does not preclude this possibility. Cardiorespiratory involvement is unusual in childhood onset SLE, but when it occurs, it is usually asymptomatic, especially in the initial period. Therefore, number 6 and 7, early recognition is important, so all childhood onset SLE should be screened with a chest X-ray, ECG, and echocardiogram at diagnosis, and may require intermittent monitoring for future progression of disease or new development of disease. For number 8 and 9, the presence of respiratory symptoms or signs such as exercise intolerance may be a first sign of underlying cardiac or respiratory pathology, although there can be a wide range of differential diagnosis. Hence, in all patients with respiratory symptoms, in the absence of acute infection, or who have exercise intolerance, these patients should be worked up for cardiorespiratory cause, including a chest X-ray, a pulmonary function test, including carbon monoxide diffusion, ECG, and echocardiogram. With regards to macrophage activation syndrome, we know that MAS is rare but a severe and potentially life-threatening complication of SLE. These childhood onset SLE patients can develop MAS at any time of their disease. Therefore, number 10, In all childhood onset SLE patients, unexplained fever should trigger not only a search for infection but also for MAS. Both of these conditions share many common features such as cytopenias, fever, and hepatic involvement, but the main difference is in MAS, the ferritin level tends to increase very dramatically, whereas in sepsis, the hyperferritinemia may be modest. For number 11, when MAS is suspected, a bone marrow aspiration should be done looking for possible hemophagocytosis to facilitate the diagnosis of MAS, as well as exclude other causes of cytopenia. However, as MAS can be rapidly progressive and life-threatening, if the child is unstable and a bone marrow aspiration is not possible, then treatment should not be delayed. Let's move on to monitoring and management recommendations of childhood onset SLE. The frequency of visits to the pediatric outpatient clinic actually is dependent on multiple factors like clinical presentation, severity of disease, as well as the age of onset. Number 1, active disease should be monitored regularly and includes a full clinical evaluation including body weight, height, and blood pressure. A basic set of investigations should be performed, which includes a complete blood count, serum albumin, creatinine, glomerular filtration rate, C3 and C4, as well as anti-double-stranded DNA antibodies. Number 2, clinical evaluation should be conducted every 2 to 4 weekly for a period of 2 to 4 months after diagnosis or after a flare, and then it can be tapered or adjusted according to the response to treatment. Number 3, all children who are receiving corticosteroids need to be checked regularly for their linear growth. And number 4, also have their disease activity regularly assessed using a standardized disease activity measure like SLEDAI-2K or P-BILAC 2004. In addition to disease activity, number 5, disease damage should also be measured annually using standardized disease damage measures like pediatric slit damage index. For number 6, we know that SLE can affect the eye in many ways, including retinopathy or optic nerve disease. In addition, corticosteroids and hydroxychloroquine, which are commonly used, can also affect the eyes. Thus, all patients with childhood onset SLE should have access to an ophthalmologist. Number 7, there is actually paucity of evidence regarding the risks of hydroxychloroquine in children. However, annual eye screening should be considered. For number 8, there is actually very minimal published evidence supporting the benefits of sun protection in patients with childhood onset SLE. But sunscreens are widely recommended to prevent the development of photosensitive rashes and as part of general disease management. Number 9, we need to support the adolescents as they go through a period of transition and prepare them for transfer to adult care once they reach adulthood. In order to have optimal outcome, we need to teach them self-management skills and be responsible for their own health. And as we know, one of the major challenges, however, is non-adherence to treatment. We will now move on to general treatment recommendations for childhood onset SLE. Number 1, there is paucity of data for the use of hydroxychloroquine in children, but adult data suggests that it is not only beneficial, but relatively safe. Thus, hydroxychloroquine is recommended for all children who have childhood onset lupus in the absence of contraindication. Number 2, as I mentioned earlier, non-adherence is a major problem in childhood onset SLE, and this non-adherence is associated with higher disease activity and disease damage. Therefore, in any child where there is a decision to either change or to modify treatment, one must actively check for compliance. Number 3, if disease is severe, such that prednisolone cannot be tapered, although on hydroxychloroquine and the patient is compliant, then an additional DMARD is recommended to improve disease control and permit subsequent steroid sparing. Number 4, mild to moderate hematological involvement. When hemolysis is present and the hemoglobin is lower than normal, then a DMARD should be added to the therapy, but the choice of DMARD has been left open due to the lack of data. And for number 5, if rituximab is required, the doses that are given for childhood onset SLE is similar to that in adults. There are additional recommendations for neuropsychiatric childhood SLE, but in the interest of time, I'm not able to cover that portion, and I will now move on to the management of lupus nephritis. Firstly, proteinuria is not always related to lupus nephritis, and the commonest cause of proteinuria in teenagers is actually orthostatic proteinuria. Therefore, in any case of mild proteinuria, either suspected or actual childhood onset SLE, it is important to exclude orthostatic proteinuria first. And in females, urine samples should not be taken when the patient is menstruating. Number 2, a renal biopsy is indicated if there is suspicion of renal involvement, for example, evidence of renal dysfunction, hypertension, hematuria, especially in the presence of reproducible proteinuria. Number 3, the presence of proteinuria, especially with impaired glomerular filtration rate, should prompt a consult with a pediatric nephrologist to discuss the need for renal biopsy. Number 4, lupus nephritis should be classified using the ISN-RPS or International Society of Nephrology Renal Pathology Society 2003 classification system. Number 5, assessment of renal biopsies can actually be challenging, and as such, a renal pathologist who is experienced in lupus nephritis should be consulted for evaluation of these biopsies. And number 6, even so, misclassification of renal biopsy is still possible. Therefore, if a patient has class 1 or class 2 lupus nephritis and continues to have persistent proteinuria after 3 months, then this is very unusual and would require reassessment of the diagnosis and renal pathology, or whether it is a misclassification in the first place or a progression to class 3 or 4. With regards to treatment of lupus nephritis, firstly, the choice of immunosuppressive treatment should be guided by a diagnostic renal biopsy when possible. Number 2, partial renal response as defined as more than 50% reduction in proteinuria to at least subnephrotic levels, and normal or near normal renal function should be achieved by 6 months and no later than 12 months after starting treatment. The long-term aim of treatment, of course, should be complete renal response with early morning urine protein creatinine ratio of less or equal to 15 milligrams per millimole and near or normal renal function. Number 4, in cases of lupus nephritis with proteinuria, ACE inhibitors or angiotensin receptor blockades should be considered as additional treatment as they have been shown to be antiproteinuric, and the combination use should be guided by a pediatric nephrologist. And number 5, where renal biopsy is not possible, for example, either the child is critically ill or there's lack of resources to safely perform the procedure, then patients with nephrotic syndrome, hypertension, and impaired renal function should be treated as if they were class 4 lupus nephritis. This is a diagram which actually shows the treatment strategies for the different classes of lupus nephritis, and I will be going through each one of them in more detail. So class 1 lupus nephritis is more common in childhood SLE compared to adult onset SLE, but there are no specific articles on treatment of childhood class 1 lupus nephritis. So based on adult literature and consensus, class 1 lupus nephritis could be treated with low-dose oral prednisolone, and if there are any other organ systems which are involved, apart from class 1 lupus nephritis, then the treatment choice should be guided by these other clinical features. If the child only has class 1 lupus nephritis, then adding other DMARDs is generally not necessary. Class 2 lupus nephritis generally responds well to low-dose corticosteroid therapy, tapering over 3 to 6 months. If proteinuria is persistent after 3 months of all corticosteroid doses cannot be effectively weaned, then one needs to relook at the renal biopsy to see if there has been any misclassification. If there is no misclassification, then adding a DMARD or switching to another DMARD that is effective for lupus nephritis is recommended. Class 3 and Class 4 are termed proliferative lupus nephritis, and these are the most common and severe forms of lupus nephritis in childhood onset SLE. It is commonly present together with Class 5 disease. When present together, Class 3 or 4 with Class 5, then treatment is as per proliferative lupus nephritis, as the proliferative form tends to show a less favorable disease course. There are no randomized controlled trials for treatment of proliferative lupus nephritis in children, unlike in adults, but only several observational cohorts and case series. The first choice of induction therapy should either be MMF or intravenous cyclophosphamide with a combination of corticosteroids. The choice of corticosteroids depends on whether it is severe disease, where one would commonly pulse with IV methylprednisolone, or if it's not severe disease, one can use corticosteroids at a dose of 1 to 2 milligrams per kilogram per day. If they are responding, then the maintenance therapy would be either mycophenolate mofetil or azathioprine. And this maintenance treatment should be administered for at least 3 years. If there's poor response and when poor compliance is suspected, then treatment with IV cyclophosphamide should be started. And if they were previously on cyclophosphamide, you may consider switching to mycophenolate mofetil. And in refractory cases, consider rituximab. For pure class 5 disease, the recommendation is to use MMF in addition with low-dose prednisolone, and the first choice of maintenance therapy would be MMF or azathioprine. Alternative options for either non-responders or those that you do not want to treat with MMF and glucocorticoids will be calcineurin inhibitors like cyclosporine or tacrolimus, intravenous cyclophosphamide, and even rituximab. What about treatment for flares and refractory disease? In general, if a patient is not responding to the prescribed treatment as expected or developing a disease flare, always first check for medication non-compliance. Number 1, for mild flares of class 3, 4, or 5 lupus nephritis, one can restart or increase the dose of prednisone first and consider a switch of DMARDs. In severe disease, one can consider the use of pulse intravenous methylprednisolone and high doses of prednisolone gradually weaned. Number 3, in those who have refractory disease, again, first check for compliance, optimize the current treatment regime before considering switching to another therapeutic agent. And number 4, in such cases, rituximab can be considered as induction or maintenance treatment in combination with another DMARD. And number 5, calcineurin inhibitors can be considered as a treatment option for lupus nephritis in selected cases, although with consideration of the potential nephrotoxicity after long-term use. So in summary, childhood onset lupus, remember, is not exactly the same as adult onset lupus and often has a more severe phenotype. Clinical research and scientific evidence is scarce in children, and treatment recommendations are largely based on adult practices and limited pediatric data. Always remember that non-adherence to medication is a major concern in childhood SLE, especially amongst the adolescents, and is often the cause of a flare. and management of these children must always be individualized. With that, I thank you for your attention.
Thank you, Dr. Sweet Bing Tang, for your elaborative talk about the latest guidelines and its explanation. So we are going to proceed to our next lecture, which is from Dr. Laura Lewandowski. So she's Assistant Clinical Investigator, Head of Lupus Genomics and Global Health Disparities Unit, NIH USA. So she's going to talk about childhood lupus emergencies, how to tame the wolf. Thank you, Dr. Laura.
Thank you for that wonderful introduction. Okay, so thank you once again for allowing me to speak at this wonderful review course today, and I will be talking about childhood onset systemic lupus erythematosus emergencies. I'm going to do this as a case-based presentation because I think these are actual cases that I've taken care of, and that really helps me frame and remember how to deal with emergencies a lot better than a traditional lecture style. My disclosures are the same as my previous talk. All these views are my personal views, and I have nothing to disclose. So during this talk, my goals and objectives are that you understand that childhood onset lupus can have life-threatening complications. I want to present 3 common emergencies in childhood onset lupus and have you understand the management of these 3 common lupus emergencies, and so that if you ever encounter them when you're caring for a lupus patient, you'll understand the algorithm. So as we've reviewed earlier, SLE is a life-threatening multi-system autoimmune disease, and emergencies in lupus are important to recognize and treat early. Early treatment can be life-saving and even organ-saving, so it can really improve outcomes. So case 1, you're called by the emergency room of an outside hospital, and there is a 15-year-old female patient with known childhood onset lupus who's presented with fever, flushed cheeks, and fatigue. She has a decreased appetite for 24 hours and nausea, but no vomiting or diarrhea. On physical exam, they report that her temperature is 38.2, her heart rate is 115, her respirations are 25, and her blood pressure is 98/48. So they want to know what you advise as part of the initial workup. And they actually ask you, is this just a disease flare? Can we just treat her lupus? And so that question of lupus flare or infection is a really tricky one to answer. I want to emphasize that in lupus patients, it's important to act as though it's infection until proven otherwise in these circumstances, and this could really save the lives of lupus patients. So it's really tricky. The symptoms of a lupus flare and the symptoms of infection are really overlapping in many ways, but lupus patients are at a really high risk for infection, and so we really need to be vigilant about infection and to treat them early. So they have abnormal immune systems, making them prone to infections. Lupus patients sometimes are immunosuppressed, and they're not really able to mount a febrile response in the same way, so they may just be like have a slightly high fever or a little bit of a low blood pressure when they're actually septic. And their immune system, they have lots and lots of reasons to have opportunistic infections. They have leukopenia, they have acquired hypocomplementemia, some of them have genetic complement or MBL deficiencies, they have low IgM, they have functional asplenia or hyposplenia, and they're on immunosuppressive medications. So a lupus patient, either treated or untreated, is are really prone to opportunistic infections. So you always want to suspect infection with fever and malaise. You want to do appropriate studies, so obtain blood and urine cultures, ESR and CRP, a complete blood count, complement levels, a urinalysis, and an double-stranded DNA. You also want to evaluate for sources of infection based on your physical exam. So if they have these symptoms and they're short of breath, do a chest x-ray. If they're having urinary frequency, get your UA and culture. And you want to treat empirically and await results. If you wait for those results to come back, they might be sicker and sicker and in septic shock by the time that you get there. So what's the most common bacterial pathogen to cause lethal infection in childhood onset SLE? Most of the studies that are done for this are done in high income settings such as the US and Europe, so this may be a little bit biased, but this is the data that we have. So it's strep pneumococcus. So it accounts for 6 to 18% of all bacterial infections in lupus. And the opsonization of strep pneumo with C3b and inactive C3b is significantly reduced in lupus versus other rheumatic diseases. So we want to make sure we vaccinate our patients against pneumococcus. And the correct way to do that in the US is to first start with the PCV13. It has a higher immunogenicity, so they're going to get a more robust response. So you start with the PCV13, but then you want to broaden that coverage to more serotypes. And so 12 weeks later, you immunize with the pneumococcal polysaccharide vaccine to get broader coverage. Okay, so that's lupus and infection. So always be suspicious, be vigilant, treat early, and you'll save a lot of lives. So case 2. So again, this is a lupus patient. The emergency room is calling you. This lupus patient has 1 day of dizziness, nausea, abdominal pain, weakness, and lethargy. She's had lupus for 2 years and had lupus nephritis at diagnosis. She had a recent flare a month ago and was put on very high dose steroids and is now tapering, and her current dose is about 20 milligrams daily. And her other medications are mycophenolate mofetil and hydroxychloroquine. So her vital signs are a temperature of 37, heart rate of 110, respirations of 20, blood pressure of 90/40. Her complete blood count and her CRP is normal, so no signs of inflammation. Her sodium is 129 and her potassium is 5.9. And when you ask her further, she said that her steroids caused her to look very different and caused some weight gain, and so she just completely stopped them a few days ago. And so this is adrenal crisis, and I've seen this a couple of times in patients that abruptly stop their corticosteroid therapy. So the predominant manifestation is shock. So they have low blood pressure, they feel terrible, but it can be kind of mild and nonspecific at the beginning. So they can just have some nausea, vomiting, fatigue, not really feel right. And then they go on to lethargy, and it can be really severe where they get confusion and can slip into a coma if it's not recognized and treated and they don't go to care. So if they're only on physiologic doses of steroids, does this protect them from adrenal crisis? And it actually doesn't. So even if you're on a very low dose of steroids, if you stop abruptly, the major hormonal factor precipitating adrenal crisis is mineralocorticoids. So even if they're on physiologic doses, they can go into adrenal crisis. And the effect can last for a really long time. So patients going into surgery or having an illness, we often stress dose them for steroids. And I think initially some people think that it's those patients with high dose steroids, but even on lower dose steroids, or if they've been weaned off steroids in like the past 6 months, you still want to stress dose them because that taking over for their adrenals, it takes a long time for the adrenals to kind of wake back up and ramp back up. So the recommendations are if they've been on high dose steroids in the past 12 months, still stress dose them before surgery. All right, so the last case is a 16-year-old lupus patient with back pain that started in the morning. She didn't have fever or any other signs or symptoms of illness. She described the pain as shooting, and then she says, as you're asking her, actually she had some difficulty walking over the past 24 hours. She kind of felt like she was shuffling. She couldn't really move her legs correctly. And then you do some further review of symptoms, and you're asking, she's got some lower extremity symptoms. Is she able to does she have normal urinary and bowel movements? And she says she's actually been unable to urinate for 24 hours. And all of a sudden this catches your attention, and now you're extremely worried and you bring her to the emergency room because you're worried about transverse myelitis. So lupus patients are at risk for acute demyelination of the spinal cord. The exact mechanism of this is still kind of being worked out, whether it's inflammatory or antibody mediated. In lupus patients, long segment transverse myelitis really increases the suspicion for lupus. And it's really important when a patient reports new onset back pain that's really acute and sudden and shooting, you really always want to think about it. This is a rare complication, but it's really important to recognize because it requires early treatment to prevent irreversible damage. So the common presenting symptoms are lower extremity weakness, paresthesias, paraparesis, or quadriparesis, depending on the level of the lesion, urinary retention and fecal incontinence, and sometimes this is the initial presentation of lupus. So a patient doesn't know they have lupus yet, and they come to the ER for these very acute symptoms, and then on further workup, we see the long segment transverse myelitis on MRI and become suspicious based on the reading, and we get further autoantibodies and blood counts, and we realize they have full-blown lupus. If they are having these complaints, it's important to do a thorough history for loss of motor or sense in the lower extremities, and loss of bowel or bladder continence or urinary retention is a huge red flag. And you want to do a neurologic exam focusing more on the lower extremities because that's more often where the lesions are. Of course, you want to do labs for lupus activity. If they're having transverse myelitis, very often their lupus is active. And if it's available, do an MRI of the spine, and depending on their symptoms, you can also consider a brain MRI for CNS lesions. And the treatment really, the first and most important therapy is pulsing them with IV corticosteroids. This is important to do as close to the onset of the symptoms as possible. It can really quench that inflammation quickly and prevent irreversible damage. So I've had patients come to me in the emergency room that absolutely could not walk and got a pulse of IV steroids and were walking out of the hospital perfectly fine a week later. If you treat this early, you can really prevent long-term damage. You want to reassess for improvement. Not all patients will respond to that initial dose of steroids and require further immunosuppressants. Some of these take a little bit longer to work, like IV cyclophosphamide and rituximab. If you're waiting for those to kind of kick in because they have long-term effects on the immune system, you can do acute plasmapheresis if you're not seeing the response. And you want to follow closely with your neurology team to monitor for improvement. So for these SLE emergencies, my key points is childhood onset SLE is a severe disease that can have life-threatening and organ-threatening complications, and early recognition of CSLE emergencies is essential to save lives, organs, and improve quality of life by preventing permanent damage. Thank you.
Thank you, Laura, for such a comprehensive talk about emergencies which we encounter as rheumatologists, and really helpful to know the patient is going in crisis and we need to escalate treatment and take action accordingly. So our next presenter is Dr. Satish Kumar. He is pediatric rheumatologist in, sorry, just a minute. So he's professor and head of pediatric rheumatology division, Christian Medical College, Vellore, India. I welcome Dr. Satish Kumar. Thank you, sir.
Good morning. I'm Dr. Satish Kumar, pediatric rheumatologist from Christian Medical College, Vellore. I want to thank the organizers for giving me this opportunity to talk to you and interact with you all. The topic given to me to discuss in this refresher course is the dermatological manifestation of primary vasculitis in children. I'll share my screen to start my presentation. Hope I'm audible and my slides are in the slideshow mode. For the next 20 minutes, I'm going to talk to you about classification of primary vasculitis in children and what are the dermatological features which you can see in children with primary vasculitis. As you all know that primary vasculitis in children often presents with various clinical manifestations which are slightly different from the adult with vasculitis, especially Kawasaki disease, cannot show in purpura, or IgA vasculitis are not seen in adults, or even if they are seen, they are very rare, and their outcome and prognosis are different. So the cutaneous manifestations give a early clue the diagnosis in children with primary vasculitis. So it's all about pattern recognition. Again, remember that primary vascular disorders presents with predominant cutaneous manifestation, they also have different visceral involvement which could be part of the disease. So once you diagnose with cutaneous manifestation, you should also look for evidence of internal organ or other organ involvement. According to Chappell criteria, the primary vasculitis in children are classified into large vessel vasculitis, especially Takayasu arthritis. Giant cell arthritis, which is another large vessel vasculitis seen in adults, is not seen in children. In the medium-sized vasculitis, we have polyarthritis nodosa and Kawasaki disease. In small vessel vasculitis, we have IgA vasculitis, cryoglobulinemia vasculitis, and hypocomplementic atrial vasculitis, which are immune complex mediated. And another group of small vessel vasculitis, which are ANCA-associated vasculitis, which are granulomatous with polyangiitis, which previously called vaginous granulomatosis, eosinophilic granulomatosis with polyangiitis, EGPA, previously called Church-Strauss disease, and microscopic polyangiitis. So this classification is mainly for adults with primary vasculitis. So ULR, Press, and Printo has come with the specific criteria, classification criteria for childhood vasculitis. So they classified predominantly, again, depends on the vessel wall involved. So if they are predominantly large vessel vasculitis, it is Takayasu arthritis alone. But if the medium vessel is involved, they divide into polyarthritis nodosa and Kawasaki disease. In the polyarthritis nodosa, you can have child systemic pan and cutaneous pan. Predominantly small vessel, they divided into granulomatous and non-granulomatous. Granulomatous is your vaginous Church-Strauss syndrome, and non-granulomatous are microscopic polyangiitis, IgA vasculitis, isolated cutaneous leukocytoclastic vasculitis, and complementic with atrial vasculitis, and other vasculitis which include Behçet disease, isolated vasculitis of CNS, Cogan syndrome, and vasculitis secondary to infection malignancy, also put under the group of other vasculitis. So I'm going to take you through 5 case scenarios to show the variety of primary vasculitis seen in children, where skin could be a clue towards a diagnosis. So here is the first case. It's a 12-year-old boy who presents multiple red spots on the legs. On review of systems, he has abdominal pain with no blood in stools. He has got joint pains involving knees and ankles without any swelling. His renal and liver function tests were normal. CBC was normal. Urine analysis was negative for any protein or blood. And his stool alcohol blood is also negative. Biopsy was done by the dermatologist, which suggestive of leukocytoclastic vasculitis with IgA deposits in the immunofluorescence. His ultrasound abdomen did not reveal any intersusception. So the diagnosis is IgA vasculitis. So in the classification criteria for IgA vasculitis, the purpura, the classical palpable purpura on the lower limbs, not related to thrombocytopenia, is a mandatory criteria. Plus they should have any one of the following, like abdominal pain, histopathology showing leukocytoclastic vasculitis, they can have arthritis or arthralgia, and they can have renal involvement in the form of proteinuria and hematuria. So other skin manifestation of IgA vasculitis include, they can have swelling of the dorsum of the hand and the scalp. They also sometimes present with bullous lesions, suggest a bullous HSP. Sometimes children can present with a red and tender scrotum, suggest of epidermoorchitis. You should remember that the skin lesions in IgA vasculitis does not need any steroids for treatment. Steroids are useful only in significant GA involvement, testicular involvement, or renal involvement. Skin manifestations usually settle with NSAIDs, especially naproxen. When you come to the case scenario 2, here is a 10-year-old boy who presented with multiple red papular lesions on the legs and arms, and a history of recurrent sinusitis. He has got 2 times hematemesis also. So this is a typical nodular lesions over the hands and the legs, and seen on the body and the face also. So his CBC was normal. He had renal failure, and he had hematuria and proteinuria. So because he has got upper airway, lower airway, and the skin and kidney, he was diagnosed as GPA. So the classification criteria proposed by the ULR or press, they should have at least 3 out of 6 criteria. Like histopathology, you should be able to show the granulomatous inflammation. They should have upper airway involvement in the form of prurient or nasal discharge, recurrent epistaxis. They can have nasal septal perforation leading to saddleness deformity as shown in the picture. They can have chronic sinus inflammation. They can have subglottic, tracheal or bronchial stenosis. Pulmonary involvement, you can take X-ray, can show cavities. They can show nodules and they have fixed infiltrates. ANCA will be positive. Again, they can have renal failure. So they also can present with non-healing ulcers. So think of non-healing ulcers, upper airway and lower airway as vaginous granulomatosis or GPA, the latest classification. Case scenario 3. So here is a 4-year-old girl who presented to the emergency department with a history of fever for 1 week duration associated with the rash over the body. On examination, she has got redness of the eyes, enlarged cervical lymph nodes on the anterior and posterior triangle more than 1.5 centimeters. She has got the classical rash which is seen on the back and the front. She also has swelling, non-pitting swelling of the hands and feet. Her investigation showed leukocytosis with thrombocytosis, mildly raised liver enzymes, and inflammatory markers are very high. So the diagnosis is Kawasaki disease. So Kawasaki disease criteria is a diagnostic criteria in childhood primary vasculitis. All the others are classification criteria. As you all know that diagnostic criteria is for diagnosis, classification criteria is mainly for the research purpose. So here the criteria, the fever has to be there for 5 days and plus 4 out of the 5 following. They will have usually bilateral bulbar conjunctival injection without any exudate. If they have purulent conjunctivitis, it rules out Kawasaki disease. They'll have cervical lymph nodes usually more than 1.5 centimeters. It is usually unilateral. It can be bilateral also. They have the diffuse macular rash. They can have erythema of a multiform rash. So in Kawasaki disease, you can have any form of rash, including atrial rash. Lip changes, red cracked lips, strawberry tongue, or diffuse erythema of the oropharynx. Extremity changes, as I showed you, they have erythema and edema of palms and soles in the acute phase and perianal desquamation in the subacute phase. Remember that all these features does not need to be occur concurrently. They can occur anytime during the duration of illness. So in Kawasaki disease is the one disease in primary vasculitis where you have a lot of skin manifestation, mucosal manifestations. So this is a classical non-purulent conjunctivitis, cervical lymphadenopathy more than 1.5 centimeters, the oral cracked lips and the typical strawberry tongue. This is the peeling, which usually happens at the tip of the fingers and the toes, which is seen in the subacute phase. In India, we also see something called BCG reactivation in the children less than 5 years old due to Kawasaki disease. And we also usually see perianal excoriation in acute phase of the Kawasaki disease. Both the things, BCG reactivation and perianal excoriation, are not part of criteria according to American Heart Association. So when you look into the natural course of Kawasaki disease, the skin changes, erythema, oral changes, eye changes comes on the acute phase. The desquamation usually comes on the subacute phase. Is usually after the 2nd week of illness. Nail changes also already demonstrated in the literature in Kawasaki disease. Case scenario 4. Here is a 5-year-old girl who has come with a history of fever for 4 months, painful nodules of the extremities for the last 3 months, and blackish discoloration of the fingers. You can see here blackish discoloration of the 4th finger, and he has got significant weight loss also. She has got hypertension, she is pale, she is febrile. So this is a classical diagnosis of polyarteritis nodosa. When you look into the investigation, she has got neutrophilic leukocytosis, thrombocytosis, she has got raised inflammatory markers, the liver and renal functions were normal, and nerve conduction study was normal, chest x-ray and manta were negative. This is a skin biopsy which is suggestive of septal paniculitis with necrotizing medium vessel vasculitis suggestive of polyarteritis nodosa. Again, we have a ULR plus classification criteria. So here, the mandatory criteria are histopathology or angiographic abnormality. Angiographic abnormality which shows aneurysm, stenosis or occlusion of medium vessels, plus one of the following. They can have skin manifestations in the form of livedo reticularis, painful skin nodules, superficial or deep skin infarctions. They can have myalgia, they'll have hypertension, they'll have peripheral neuropathy or mononeuritis multiplex. They can have proteinuria and hematuria. So the polyarterial livido-reticularis rash, they present with gangrene. They can have non-healing ulcers. They can have subcutaneous nodules. And they also have cutaneous skin infarcts as a form of presentation. As a pediatric rheumatologist, as a pediatrician, it's very important to differentiate between the cutaneous and systemic pan because the treatment is different for both. So in the cutaneous pan, as the name indicates, it's limited to skin. Sometimes they can have polyneuropathy, arthralgias, and fever also can be associated with cutaneous pan. Systemic pan, as the name indicates, they have a lot of neurological involvement, systemic involvement. Usually cutaneous pan follows streptococcal infection in children. It's a benign cause, chronic and relapsing can be there in cutaneous pan. Systemic pan is a very severe disease, so we should be very aggressive in treatment. If we don't treat it aggressively, it can be cause fatal in children also. This is my 5th case. So here is a picture of the first picture is a girl with a recurrent painful nodules, which you can see, which was there in the body and the extremities. And the second picture is brother. He also developed livido-reticularis like skin rash and tender subcutaneous nodules. So the biopsy was consistent with medium muscle vasculitis, suggestive of polyarteritis nodosa. But why both the children in the same family has a similar disease, polyarteritis nodosa at the same time, especially only systemic features, without any systemic features, only cutaneous pan. So we thought of a disease called DADA2 disease. It's a monogenic disorder. It is autosomal recessive disorder in CECR1 or ADA2 gene encoding for ADA2. So any child who presents with early onset stroke, with increased inflammatory markers, with symptoms of skin signs of livido-reticularis, large reticular pattern, nodules or skin ulceration, you think of DADA2 disease. So consanguinity is very important because it's autosomal recessive. Usually they don't respond to conventional treatment with steroids and azathioprine like what we do in polyarteritis nodosa. The treatment of choice is TNF-alpha inhibitors. So this is my last case. This is another 3 years old child who presents with atricarial skin lesions with itching. So he was seen in multiple pediatricians, was given all the types of antihistaminics almost for 2 weeks. It resolves for a little time and comes again because he was referred to us in view of persistent atricarial lesion. And when I went to the history, the child has got fever also. He was having burning sensation than itching. Usually itching is part of, we all know that the classical atricaria due to allergy. Here he's got burning sensations. When I touched his skin, it was warm and it was painful also. They can have response to fever and arthralgias can be there. There will be lack of response to antihistaminics. So the diagnosis is atricarial vasculitis. The biopsy was consistent with atricarial vasculitis. So in the atricarial vasculitis, you have to do complements. If the complements are low, they can have severe disease. If the complements are normal, they have benign course. Usually they settle with short course of NSAIDs or steroids. We'll settle this atricarial vasculitis. Rarely we have to treat with high dose immunosuppressions. So how do you manage these children? So if they have skin is only like a leukocytoclastic vasculitis, if it is a self-limiting episode, rest and trigger elimination, antihistaminics can be tried if they have itching. Topical steroids sometimes help only for the cutaneous manifestations. But if it is recurrent, especially if they have recurrent IgA vasculitis involving only the skin, you can try dapsone or colchicine. Glucocorticoids and immunosuppressants, especially azathioprine or mycophenolate, can be used to prevent the recurrence. Suppose if there is a skin vasculitis is part of systemic disease, when you treat the systemic disease with high dose steroids and immunosuppression, the skin manifestation usually disappear. Take home message. So most of the primary vasculitis, except Takayasu arthritis, has got skin manifestation. Very important thing as a clinician is to pattern recognition. The whole of pediatric rheumatology is pattern recognition. If you recognize the pattern, you don't need to do further tests to confirm. Mostly blood tests and serological tests are to confirm the diagnosis than for etiology. So if any child presents to your OPD with purpuric rash, especially of the lower limbs or any arterial area, you always think of small vessel vasculitis like Kenoxon purpura. If they have systemic symptoms, you think of ANCA-associated vasculitis, especially when they have upper airway, lower airway, and kidney. When a child presents with nodules, lipidoreticularis, gangrene, non-healing ulcers, you think of median vessel vasculitis, especially polyarteritis nodosa, which can be cutaneous or systemic. Kawasaki disease is classically, as I told earlier, fever for 5 days, conjunctivitis, oral changes, lip changes, tongue changes, edema of the peripheries with skin rash, you think of Kawasaki disease. And large vessel vasculitis, usually Takayama arteritis, presents with either pulseless disease or with hypertension. Usually they don't have rash. Treatment of cutaneous vasculitis is usually symptomatic. You treat the underlying disease, they usually resolve. Most of the cutaneous manifestations respond well to your systemic treatment. Thank you very much for patient listening. I want to thank the organizers once again giving me this opportunity to talk on this pediatric rheumatology symposium conducted by the Pakistan Society of Rheumatology. Thank you very much.
Thank you so much, Dr. Satish. It's a really helpful session and helped us to understand the vasculitis in childhood.
I just want to thank all the speakers for their fantastic talks. We want you to come online, please, for the Q&A.
Thank you. And Laura, if you can come on stage. So we have quite a few questions for Laura, but I've got one question for Dr. Satish. I will start with you. So Dr. Satish, there's a question for you. So child case of Kawasaki disease on steroids and refractory to IVIG, what treatment option would you suggest next?
So the IVIG resistant Kawasaki disease, we have 2-3 options. So whether you give the second dose of IVIG, again 2 grams per kilogram, or you give pulse steroids followed by oral steroids for 2 weeks, or you give infliximab. We try to use infliximab more, 5 to 10 milligram per kilogram of infliximab. Infliximab is a monoclonal antibody against TNF alpha, and this works better than steroids and IVIG. The cost-wise also is better than IVIG in India. So in our unit, we always use infliximab if they are IVIG resistant Kawasaki disease.
Okay, thank you so much. Thank you so much. So next question is again for you. So it's commonly associated hematological malignancy with polyarteritis nodosa you see in your practice?
No. So remember that in children, we don't see malignancy associated with any of our rheumatic diseases. So usually dermatomyositis is associated with malignancy in adults. But in children, I never came across any child who has got presented with polyarteritis nodosa and turned to be malignancy. Malignancy also can have subcutaneous nodules, tender nodules. The biopsy should pick up the malignancy with cutaneous lymphoma especially.
Okay. That's great. Thank you. So next question is for Laura. So what are the absolute indication for IVIG or plasmapheresis in transverse myelitis due to SLE?
Thank you for that question. And I actually meant to include IVIG in my talk, so I'm glad somebody brought it up in the Q&A. So I think, the initial treatment for transverse myelitis is high-dose corticosteroids in a pulse. But beyond that, the next best therapy is not really understood. And the reasons for that are that it's a rare complication, and so it's mostly case series, and so it's, people are kind of trying what they have at hand, and it works in most patients some of the time. So I think if you've given your patient high-dose corticosteroids, and you need a treatment that works fast. IVIG is certainly something that has been tried and been proven to be effective in some cases. So has plasmapheresis. I've actually seen both of them used in the same patient, so they get one or the other, and if that doesn't work, you can give plasmapheresis, and then if that isn't working, IVIG. You can give IVIG, and if that doesn't work, you can give plasmapheresis. You're going to pherese off the IVIG you just gave, but if it wasn't effective, then you need to move on. So I think it's such a organ-threatening manifestation with irreversible damage, so you want to be aggressive in your treatment early on. And there's a list of things that you can try, and if one doesn't work, I would recommend quickly moving to the next.
Yeah.
Can I just ask, do you have a preferred hierarchy? Do you rather go with what first?
So in my experience, I usually give high-dose steroids and start, if I don't see a response like within hours, then I start a DMARD. Usually rituximab, I just find that a little bit better for antibody-mediated diseases. And then if I don't see a response quickly after those two, I'll probably move to pheresis.
Right, that's great. And your experience with IVIG, would you like to share, in terms of response and?
Yeah, I've only seen a few cases of this, so I think all of my cases have responded to those initial therapies. So beyond that, I don't have personal experience with IVIG, but I have seen lots of reports in the literature where it's been very effective in cases that are refractory to other, like the corticosteroids or the pheresis.
Okay.
Can I just ask, sorry, I just wanted to, you mentioned rituximab, but doesn't that kick in, like it takes time?
It absolutely does. So I start it early because I want that to start the clock as soon as I can, and then I use other bridge therapies in the meantime because it will take weeks to work.
Right, that's great. And just last question again about the same entity. So for transverse mellitus, as you mentioned, the time frame is very important. When we can say it's too late in terms of days, weeks?
So, I think that again, because it's rare, there's probably a range. The sooner the better. Within days, there's been reports of there still being a chance for a therapeutic window. I think by weeks, you've probably missed it, but I would still try because you never know how much active inflammation is happening in real time. So I would always treat and then see how much of a response that you get. But the longer the wait, the less chance of you get for recovery.
So next question for you again. Before that, I would like to mention we have code cards as well we're distributing, and if audience have any questions, please share with us. So Laura, again, question for you. What are the absolute, so we discussed that. Then again, so role of CSF analysis in a patient with childhood lupus with normal brain imaging and vague symptoms, how you go about it?
So a CSF analysis can be useful sometimes if they're having neuropsychiatric symptoms. Sometimes you will see pleocytosis without an infectious cause, and that can be a sign that there is active inflammation going on in the brain. And it can help rule out other things, especially if it's an earlier case and you're not quite sure what's going on. So, CNS lupus and other things that cause seizures or psychosis or changes in motor function like MS, you can rule some of those things out with antibody studies and oligoclonal bands. And then, if you rule out the other things, then you can look at CSF for pleocytosis. Sometimes they're having brain inflammation and you don't see abnormal CSF studies, which gets trickier, but it's just kind of, you have to kind of build evidence over time.
Okay, that's great. Thank you. And next, again, question about the CNS childhood lupus. Is there any, is there any?
So especially in CNS, if the patient is having CNS involvement in childhood lupus, is there any preference for immunosuppression with cyclophosphamide? And is there any role for plasma exchange?
Is there any role for?
Is there any role for plasma exchange?
For plasma exchange. So definitely yes to both of those. So if a patient is having CNS lupus, I think that most people would treat very aggressively, and that would include high-dose corticosteroids and cyclophosphamide. And that's probably, again, this is a rarer manifestation, so these are all case series, and there's not like a robust prospective clinical trial in children, but I think a lot of people would manage that way. And then if they're having acute psychosis, and there's evidence of active CNS inflammation, then while you're, again, bridging therapy while you're waiting for that cyclophosphamide to kick in, you can certainly do plasmapheresis, and I've seen that done many times.
Okay, thank you. So the next question is from Dr. Santesh. In multi-system Kawasaki disease, due to especially with concomitant COVID disease, is treatment for resistant disease the same? So you have a multi-system Kawasaki disease due to COVID-19. Is treatment for resistant disease the same?
MIC associated Kawasaki disease, we always start on steroids plus IVIG. If it is a normal Kawasaki disease without association of MIS-C, we always give only IVIG 2 grams per kilogram. But if it is associated with MIS-C, that is the protocol. You all know that MIS-C is a new disease. So we always start with steroids 1 to 2 milligram per kilogram plus IVIG. So that's the only difference we see in children with MIS-C associated with KD.
Okay. So thank you. Next question is, what's your experience with treatment of PAN associated with hepatitis B virus in children?
So the systemic PAN is a rare disease in children. So we always see cutaneous PAN, more of cutaneous PAN than systemic PAN. So in our experience, I have seen only one child with hepatitis B associated with systemic PAN, which the child was doing well with the current treatment. So I don't have much experience with a lot of children with hepatitis B associated with PAN.
Thank you.
Yeah, so we've got another question for you. So how can we differentiate between acute lupus skin manifestation with Stevens-Johnson syndrome? The other.
When you look into the dermatological, this is for me. Yeah. So, so my talk is only on primary vasculitis, so that's why I didn't touch about the lupus skin manifestations. So lupus skin Stevens-Johnson could be like a skin manifestation of SLE. So the biopsy may help you to differentiate, because in lupus, with the skin manifestation, we'll have immunofluorescence also positive, which cannot be positive in Stevens-Johnson's. And you also look into the other blood parameters to decide whether it is Stevens-Johnson or it is SLE. Clinically, both biopsy will help you to differentiate, and other clinical manifestations also.
Laura, do you like to add anything on this?
I think that was a very comprehensive answer. I would just add that, I think that, just assessing for other manifestations of lupus is probably the biggest distinguishing factor.
Okay, that's great, thank you. So next question for you, Laura. Beside lupus nephritis, we use rituximab any cases with this with SLE? I mean, any other indication of rituximab use apart from the lupus nephritis?
Yeah.
Especially, Laura, do you use it for CNS?
I do use it for CNS lupus. I actually, it really depends on the patient and their constellation of symptoms. So if they have CNS lupus or lupus nephritis plus like a hematologic manifestation, or sometimes they have really bad arthritis that isn't responsive to other therapies, I will add rituximab in those cases. But it really is thinking about the patient. It's also a nice medication because you give it once and it lasts for a long time. So if it's a patient that's having trouble with compliance or taking a medicine every day, it can be a nice choice for that case. So it's really kind of part of the comprehensive management of lupus patients, but I do like it, and I think it's a very effective therapy for many of the manifestations of lupus.
That's great. And what about adalimumab?
It's more with, sweeping, I just wanted your take on use of rituximab in lupus. I mean, is it similar to what Laura has mentioned, or have you used it in other settings as well?
Generally, it's similar to what Laura has mentioned. So we use it for lupus nephritis. Some of those who have very severe disease, even at onset, if they have renal impairment, we usually will give them high-dose steroids, rituximab, and cyclophosphamide, sometimes plasmapheresis before the rituximab. And I also use rituximab sometimes for refractory autoimmune hemolytic anemia and lupus. That seems to work quite well. I've used it for refractory thrombocytopenia and lupus, but have not had very much good success with that.
Okay, thank you, thank you, thank you.
So just another question about regarding belimumab, your experience with that and any indication you're using for.
So belimumab, I have a little bit less experience using because it hasn't been approved in children for a very long time. I have seen it, I really feel like it is an effective therapy added on to some of the other conventional DMARDs and therapies. I find it really useful for some of the skin manifestations. I found it useful for arthritis. I haven't had much experience with lupus nephritis yet, although it is indicated now. I will say the biggest bang I get from belimumab as is a steroid lowering therapy. So when I add belimumab and a patient that I previously have been unable to wean off steroids, and like weaning my patients off steroids is a big therapeutic goal for me because they're such a great medicine for inflammation, but they have so many unwanted side effects that I really try to wean those aggressively. And so when I add belimumab to a therapeutic regimen, I can really wean those steroids off a bit quicker.
That's great, thank you. So next question is for Dr. Swee Ping. Which DMARDs first should we choose for SLE in the childhood lupus, basically with hematological disorder? Which DMARDs would you like to?
So usually, I think in the recommendations, they had not specified the DMARD because the data is actually quite limited. Generally, I would use azathioprine first. And usually if azathioprine doesn't work, then I would move on to mycophenolate mofetil.
Okay,
I have a question regarding azathioprine. Do you do TPMT levels regularly before you start azathioprine?
Yeah, so we don't do it routinely before we start, but we will monitor the full blood count. I have seen a few who develop pancytopenia, but thankfully they're all reversible. Took some time, but they go back to normal.
This question is from Sweeping. How often you see side effect of cyclophosphamide, ovarian failure in female child when they were followed in adulthood?
I would say I don't have very many patients who have gone into the adulthood and and have had pregnancies, but we've had childhood patients who've gone on to deliver children despite having 12 doses and sometimes even 18 doses of cyclophosphamide. A large part of it depends on when they had the cyclophosphamide. So generally, the younger they had cyclophosphamide, especially if it's pre-pubertal, then the risk is lower. And of course, it also depends on the cumulative dose, but it's much lower than what is reported in adults in the reproductive age group.
Okay, thank you. So the next question is again from you. Can childhood lupus just present with neurological manifestations without any other lupus-specific manifestation?
Is it for me?
Yes, it is from you. Can childhood lupus just present with neurological manifestations without any other lupus-specific manifestation?
Yes, they can, yeah. So in those cases, sometimes it is actually quite difficult and you really need to, do all sorts of investigations, your CSF analysis and MRI, MRA, MRV, autoantibodies to try and find any other sign that it might be lupus, and you need to exclude other causes that may present with similar symptoms. But they can sometimes just present with a single organ involvement.
thank you.
For all of you, actually. So, you spoke about the cumulative dose. We were just having an informal discussion. We do use a lot of cyclophosphamide in children. It works well. Kids get forced to be compliant with treatment, because that's an issue as well. So what is the cutoff cumulative dose that you're talking about, Sweeping and Laura and Satish, you can just add on What have you been? So we'll start with sweeping.
Usually about 10 to 15 grams.
So in our center, we don't use cyclophosphamide much a lot because we try to use rituximab upfront than using cyclophosphamide. Sometimes only for the renal involvement, if they have a lot of crescents in the biopsy, resulting in renal failure, we try to give 2 or 3 doses along with steroids, and we start on MMF very early, or we use rituximab. So we don't really go and give like 6 doses or 8 doses. We don't use that. Maximum of 3 doses of cyclophosphamide. That's what the practice we follow in our unit.
What's your experience?
You know, I am trying to remember in my head what the maximum dose cutoff, and there's probably guidelines around this, but I will have to say that where I trained, we used a lot of cyclophosphamide, especially for lupus nephritis, and you know, it's tricky to say how many go on to have fertility issues, because sometimes when people go into the adult world, they go into different places. So sometimes they stay at your center and sometimes they go off into private practice. So I don't have like rigorous data on everybody that I've treated, but I have had personal experience with patients who got a lot of cyclophosphamide and had absolutely perfect family planning all according to the way that they wanted it, no problems with fertility. So I haven't really personally ever seen anybody that had infertility from a lot of cyclophosphamide. We do ovarian suppression with our regimens, so that might help. Also, I like to remember or talk to, when I'm counseling patients, reminding them that active disease is also very bad for fertility, and if the patient dies, that also impacts their fertility. And so when you're thinking about severe lupus nephritis that isn't responding to anything else, a little bit more cyclophosphamide, I think, is the lesser of two evils.
I think we... requesting Professor Nikat, Professor Tahir Masood, Dr. Tajwar to also join us, and you know, we can have a panel discussion and go on with the Q&A. You can continue the question.
So again, the next question is from Dr. Laura. A patient with a childhood onset lupus with renal involvement are at, usually are on long-term steroids and at risk of osteoporosis. What agent do you prefer for prevention and treatment of osteoporosis in children, and for how long?
So I think it depends on the severity. I will say that you know, I do think about bone health, and so I think about it in kind of a multidisciplinary, holistic sort of way. So I recommend things that are good for bone health, and I counsel patients on bone health. So I tell them that they're at risk because of their disease and their treatment. And I recommend that they eat foods rich in calcium and vitamin D. I check vitamin D levels. If they're low, I supplement aggressively. I recommend weight-bearing exercise, so you know, as much as they can do based on disease activity. And then if there's any sign of disturbed bone health, so if they have a non-traumatic fracture, I do a DEXA and I follow those. There is recommendation in these patients to use bisphosphonates if there is sign of really severe osteoporosis. So it's kind of a multifactorial algorithm, but I try to prevent us getting there by diet and exercise recommendations up front.
Okay, so last question again, same theme basically. How do you monitor metabolic and endocrine side effect the use of the steroids in these childhood lupus patients?
Yeah, so I think that is probably a pretty similar answer to the first question. So, you know, I don't do routine DEXAs on every patient, but I do it if they have signs of osteoporosis and then good bone health counseling.
Okay, and any role of growth hormone? We just talked about another patient where she had stunted growth and she had to use, and unfortunately she lost a follow-up, so she was keep taking steroids. So the role of growth hormone in these patients, or how do you go about?
So for lupus patients that have growth delay due to corticosteroids, I've never had to use growth hormone. Usually the growth delay is acutely responsive or is in the acute phase where they're on high-dose steroids to get their disease under control. And in almost every case, I'm able to use DMARDs so that I can wean those steroids off. And most patients you can watch their growth chart, they'll kind of drop off when they're on the high dose of steroids, and then they'll catch up when they're weaned off. And so even though it is in that phase of acute growth, most patients do well with that. So I haven't had personal experience using growth hormone. The only patients that I've had to use it in have been from growth delay from other causes, and that's a different topic.
Okay, so it's basically the good control of disease usually prevent us from these.
Yeah, and that's specific to lupus. There are other diseases with severe complications that do cause growth delay, and it really is disease specific.
Thank you. We have so many questions, and probably we can then send, hopefully you'll be able to answer the questions. I just want to thank Satish and Sweeping and Laura, of course, and for joining us. We're just going to close with comments from the expert panel, Professor Masood Tahir, who's a pediatrician, and he set up a pediatric rheumatology department at Children's Hospital. And so he's had a lot of experience with it. Professor Nighat Mir, my mentor, and I think my first step towards pediatric rheumatology was with her encouragement. And Dr. Tajwar, who is a very dear colleague, and she has come all the way from United Kingdom to be part of this. So just briefly, their comments, and once again, goodbye and thank you from me.
It was an absolute pleasure, Sumaira, our champion for children with rheumatic diseases. You've done so well. You make us proud, not only nationally but internationally, and you have really fought their case very well. And the entire team, Saira, Bilal, have done a wonderful job with as a team to make it a great success. And congratulations, it was fantastic. And Laura, I really admire your coming all the way to Lahore to make it a real success. Thank you so much.
And we hope next time Satish and Sweeping and the rest can come and join us as well.
Yes, and it was great to hear Satish, so close to us, though far away, and also Sweeping. Great. They were great talks, and we really learned a lot. And would really like to have comments from Dr. Tahir, who is also doing a lot for patients with
Thank you very much. First of all, I think I must express my appreciation and sincere gratitude for inviting me to this conference and symposium. It was really a pleasure to be part of this activity, and I really benefited from it all. And I think all the presentations were excellent, and these were very informative, and I'm sure that all the participants must have learned from this. And I would express my appreciation for Dr. Sumaira and her team to conduct this activity, and I think that this would go a long way in establishing these subspecialties. Pediatric rheumatology is relatively, I would say, a new and relatively less populated pediatric subspecialty, and this still needs to be recognized by the College of Physicians and Surgeons for a second fellowship. But nevertheless, we are cognizant of the fact that pediatric rheumatological disorders, they are on the increase, and it's a whole spectrum of the disorders. So there is a need that more and more pediatricians are trained in pediatric rheumatology, and ultimately they would treat the children who would lack the care which they need and would lack the diagnostic and treatment services which are required. And I think the Children's Hospital Lahore has taken the lead in that, and the people who have been trained here, they're working in other centers in Pakistan, and that would pave the way to build this subspecialty further, and that would be beneficial for the appallingly high pediatric population, and obviously the rheumatological disorders are there. So there's a need to have more trained pediatric nephrologists so as to give optimum care to these children. So thank you all, and thank you all the speakers for being there online, and especially Laura, who has traveled all the way for being here. I extend my appreciation for all of them.
Thank you so very much for the invite. It's such a wonderful opportunity to come back home again, especially because you invited me. And I am working in the UK at the moment, but I'm very much part of PSR, and I'm doing a weekly clinic in Peshawar. And I'm really grateful to Allah to be part of this society. I've often sent you patients for second opinions, and it's so great to have you out there, because where I work in Peshawar, obviously some of half our patients are from Afghanistan as well. And our challenges are so much more different to what we see in the UK and the US and, you know, countries that have better facilities. But we're definitely getting there. And I think just the sheer effort and the put together, working together, we achieve so much. And it's so wonderful when we save lives and we see those children recover. That wouldn't have happened without, you know, all of you guys working together. And inshallah, it's only going to get better with all this new program in APLAR I've attended from 5 o'clock in the morning in the UK. But it's wonderful. Thank you. Keep up the good work.
Thank you so much, everyone. It's been brilliant. So we are starting with our next session. And
Bye-bye, Sweeping and Tatish. Thank you.
Thank you.
Thank you so much. Yeah, bye.
So we are starting with the next session. I will invite Dr. Taqaddus Khalik, and tea will be served in next hour. Thank you.
Bismillahirrahmanirrahim, and a very warm welcome to the second session of this second PSR, Pediatric Rheumatology Review course, in collaboration with APLAR Peds Rheumatology Special Interest Group, endorsed by APLAR Academy. My name is Dr. Taqaddus Khalik, and I'm working as Associate Physician Rheumatology in Federal Government Polyclinic Hospital, Islamabad, and I'm the moderator for this second session. We have had a very exciting and informative first session earlier in the day, and I can guarantee that this session is going to be equally exciting. Before I formally start with the session, I would like to introduce the chair for this session. We have with us Dr. Samia Naz, who is a consultant pediatrician working in Children's Hospital, Lahore, and she has special interest in pediatric rheumatology, and she's been practicing it for the last many years. Madam, can you please join us on stage? Okay, that's fine. We also, in our panel of experts, we also have two of the renowned pediatricians of Lahore. We have Professor Fahim Afzal with us. He's Professor of Pediatrics at Amiruddin Medical College and Lahore General Hospital. And it is also worth mentioning here that he's the first Fellow of Pediatric Infectious Diseases in Pakistan. Welcome to you, sir. And we also have with us Professor Najaf. She's Professor of Pediatrics and Allama Iqbal Medical College, which also happens to be my alma mater. Now we formally begin the session. We have lined up 3 state-of-the-art lectures for you, which would be delivered by 3 renowned pediatric rheumatologists of the APLAR region. First lecture is by Dr. Rebecca James, who's a consultant pediatrician working in Queensland Children's Hospital, Australia. And she would be delivering a talk, When to Think of a Rheumatological Disease in Kids. And I think no review course in pediatrics can be complete without such a lecture. Dr. Rebecca James for you.
Good afternoon, everybody. My name is Rebecca James. I'm a paediatric rheumatologist from Brisbane, Australia, and it's really a delight and a great privilege to be invited to speak today and to be part of this meeting. I'll be talking about when to think of rheumatic disease in children. I'd like to begin my talk by acknowledging the traditional custodians of the land on which we walk, work, talk and live, and acknowledge and pay my respects to Aboriginal and Torres Strait Islanders, elder past, future and present. So to begin with some general tips about recognising rheumatic disease in childhood, the first thing I'd say is beware the child who keeps presenting with musculoskeletal symptoms. So we all know that musculoskeletal presentations, sports injuries, benign nocturnal limb pain, so-called growing pains, are very, very common in childhood. But the child that continues to present over and over again with musculoskeletal symptoms, particularly symptoms that are consistent and persistent, they keep happening and they keep happening in the same place, is really something that should flag some alarm bells for you. And we know that on average, children with juvenile arthritis present to something like 9 practitioners before they're ultimately diagnosed. My next tip is that children with rheumatic disease often have remarkably normal pathology. So don't be falsely reassured by the presence of normal inflammatory markers or by a negative rheumatoid factor or a normal CK. Even children that are considerably unwell can often have really quite unremarkable bloods. A consistent theme of this talk will be that malignancy can mimic almost all forms of rheumatic disease in childhood, and that you really do always need to be alert to it, whether that's as a neoplastic or paraneoplastic phenomenon. And something that I've become increasingly aware of over recent years is to consider the nutritional state of any child with multi-system disease. So particularly in Australia, the children that we see with profound nutritional deficiencies are often those on the autism spectrum, and scurvy, for one, can certainly mimic a number of rheumatic diseases very closely, but also concomitant bowel involvement such as inflammatory bowel disease or celiac disease is quite common, overlapping with rheumatic disease in childhood. My next tip is that examination of the hands is often very, very telling. And in fact, I'd go so far as to say you can almost make a diagnosis based on the hands alone for many paediatric rheumatic conditions. So whether that's Gottron's papules in dermatomyositis, Raynaud's phenomenon in connective tissue disorders, sclerodactyly, the pitting, ridging and onycholysis of psoriasis, dactylitis, nail fol capillary changes or absent peripheral pulses in a medium or large vessel vasculitis, there's really a lot to be gleaned peripherally. I would say that there's often a family history of autoimmune disease, but that almost always needs a bit of teasing out. So very often you'll ask the family if they have any autoimmune history and they say no, and then you ask specifically about thyroid, psoriasis, lupus, celiac disease, type 1 diabetes, and very often it turns out that there is more than one family member, but it's not necessarily recognised as autoimmune disease. So you do have to be quite specific on history taking. The trio of fever, rash and arthritis, plus or minus myositis, is obviously highly suggestive of rheumatic disease, but always beware cancer or infection. So the holy trinity of rheumatic disease, infection and malignancy will plague me and all of us throughout our careers, and we must always be vigilant to it. A positive ANA, of course, tweaks the attention of a rheumatologist, but particularly if it's of a high titer, so greater than 1 in 80 in particular, but the higher it goes, the more likely to be pathologic. If there's a suspicious history or examination, so we not infrequently see teenage girls that have an ANA of 1 in even 2560, but without associated symptoms or signs. And of course, if there's other associated positive serology, so antiphospholipid antibodies, double-stranded DNA, ENA, C3, C4. And I guess my final general tip is to look hard for rashes because they're often there but in hiding. So look behind the ears for psoriasis, along the natal cleft, around the umbilicus, all for psoriasis. The palms and soles can be associated with vasculitis or a pustular disorder, a serratiform disorder. Look at the palate for lupus, at the nail beds for dermatomyositis, lupus and connective tissue disorders, the fingertips, the genitals. So I'll begin my talk by running through some of those rashes. So behind the ears, classic for psoriasis, and under the hairline or behind the ponytail. So I always take the time to look for these spots in children. There's another classic example behind the ears. They've often been diagnosed as eczema or treated as eczema. Around the umbilicus, the natal cleft and the genitals are not uncommon for psoriasis. Still's rash, which is the rash of systemic onset arthritis, can be quite variegated, but many cases also have a very typical appearance. And as we all know, it's classically described as the macular salmon pink rash, usually on the limbs and the trunk, but it can occur on the face or the neck. And in particular, I tend to see it on the inner thighs. You can see on this picture just over here that there's very clear dermatographism as well, which is often a feature of Still's rash. And something to look for. Now, the Still's rash, not universally, but often comes and goes with a fever and is almost always more prominent at the time the child's having their quotidian fever. Here's some more examples of it. And again, and you can really see here this kind of classic inner thigh appearance that is so often present with Still's rash or with systemic onset arthritis rash. So I've got two pictures here. One is on the left, livedo reticularis, and on the right is livedo racemosa, which are very similar in appearance, as you can tell, but livedo reticularis is not always pathologic. It can be physiologic, particularly what we call cutis marmorata, which is physiologic and related to temperature changes. But on the right there, the racemosa, which is very likely to be linked to pathology, including rheumatic disease, so things like antiphospholipid syndrome, polyarthritis nodosa, lupus, dermatomyositis. Now, the differences between them are subtle but real. Racemosa is usually more generalised with a wider distribution and can be found on the trunks and the buttocks as well as peripherally on the limbs. And its lesions are more irregular. So both of them tend to have these quite circular ring-like lesions, but in livedo racemosa, they're often broken rings. And in racemosa, of course, they're persistent, whereas in reticularis, they often come and go with temperature changes. So the malar rash, which we get referred so often. So the top two pictures here are both pretty typical versions of a malar rash, all in young children, though of course they can extend right through adulthood. The malar rash can extend down into what I call the beard distribution as well as onto the ears and up on the forehead. So even though we call it malar or butterfly rash, that erythema can really extend down around the chin and even onto the neck as well. The bottom picture is physiologic, non-pathologic, so strawberries and cream complexion. And you can really see the sparing of the nasolabial fold is quite sharp in a classic malar rash, whereas it's more of a fading away with that strawberries and cream complexion. Fever, onto our next symptom. So fever and symptom patterns can be really telling in paediatric rheumatic disease because it very often follows a pattern, whatever that pattern may be. So running through a few of the more typical ones, fever at the same time every day with an associated rash, both of which then subside until the next day, is the classic quotidian pattern of systemic onset arthritis. Now, it doesn't have to be every day, day in, day out. Very often these patients will have a day or two when the fever goes away and you invariably discharge them from hospital, but then it comes back again. But it's that idea of a quotidian, daily, persistent fever that doesn't happen all day, every day, like you would see, for example, in Kawasaki disease, but that just keeps coming back. It seems often in the early evening to sort of nag at the patient. A completely different fever pattern, but nonetheless equally telling, is high fevers which last 2 or 3 days at a time that occur with strict periodicity. So it doesn't have to be 21 days, but the patient will often say to you every 21 days, every 26 days, every 28 days, almost to the point where they can mark it on their calendar. We call that clockwork periodicity, and that can be associated with the periodic fever syndromes, but that strict periodicity often goes with PFAPA and sometimes cyclic neutropenia. Rheumatic disease, inflammatory rheumatic disease often is associated with morning stiffness, so that morning gelling, and whereas biomechanical or growing pains usually get worse in the evening, particularly after a big busy day. Always think of rheumatic disease and malignancy and infection in fever that persists more than 14 days. So the definition of Still's disease is fever that goes on for 14 days. And consider rheumatic disease and fever that keeps coming back as well, that seems to subside but just never quite manages to quell. So I couldn't give a talk on paediatric rheumatic disease without talking about inflammatory markers and making the particular note that many children with rheumatic disease, particularly oligoarticular arthritis, who are also the subgroup that often have the most profound diagnostic delays, often have entirely normal inflammatory markers, and that doesn't at all or in any way preclude a diagnosis of rheumatic disease. In fact, on the flip side, it's somewhat unusual to see triple figure inflammatory markers in rheumatic disease. Obviously, in systemic onset arthritis, which is a highly inflammatory state, or macrophage activation syndrome, we do see it. And this is not a hard and fast rule. But in general, children that have ragingly high inflammatory markers, I would usually think about infection first. I remember when I was in med school and some of my lecturers told me that an ESR was not helpful, or that there was no point in doing it. But as a rheumatologist, I pushed back on that quite profoundly. And you do get a sense, based on the pattern of the ESR and the CRP, of whether there's likely to be a rheumatic disease versus an infection or something else going on. So if the child has a high CRP alone, that is often, not always, but often an infective cause. If they have a high ESR and a CRP, then that's piqued my interest more. And if they have a high ESR alone, then I'm very interested. And that's classically associated with lupus, a high ESR and a normal CRP. Be mindful that patients that have had IVIG, which many patients with a kind of a nondescript inflammatory condition have, will often have a falsely elevated ESR. So after, for example, IVIG and Kawasaki disease, the ESR becomes unhelpful. So as I nodded to, certain patterns can indicate certain conditions. So lupus classically has a high ESR and a normal CRP, although if they have serositis, arthritis, or infection, the CRP will be elevated in a lupus patient. And if you see a discordance, so a rising CRP but a falling ESR, you must think about macrophage activation syndrome, which is a sepsis-like syndrome. And many a clinician has been falsely reassured by the presence or by the falling ESR, when in fact that's an indicator that things are really going haywire. And finally, we do use serum amyloid as a useful marker, particularly of autoinflammatory syndromes and in monitoring the risk of systemic amyloidosis. So juvenile idiopathic arthritis, going to some specific diagnoses now. I think of JIA when the pain is consistent and persistent. So there's lots of 3 or 4 or 6 or 8-year-olds that complain of knee pain or leg pain, but I get more interested in or more suspicious that it could be arthritis if the pain consistently happens in a joint, so it's very specifically articular pain, and it tends to be the same joints over and over again. Now, of course, there are forms of arthritis that are migratory, classically post-streptococcal. But if we're thinking about juvenile arthritis, it can wax and wane, but it tends not to go away, and it tends to be persistent and consistent in the same joints as a kind of a rough guide. A history of joint swelling as opposed to a history of joint pain is very indicative of inflammatory disease, and would be enough for me as a rheumatologist to triage that referral as a category 1. And asymmetry is a very, very useful sign in clinical examination for rheumatic disease. So looking not just at the appearance of the joint, but also the range of the joint. So I don't have in my head kind of magical numbers of what is and isn't normal range for an elbow or for a knee or for an ankle, because there's so much variability from individual to individual. What I look at is how that compares to the contralateral joint. And of course, it is entirely possible to have, and in fact quite common to have arthritis in bilateral joints, but it would even then, there is usually some degree of asymmetry in swelling, in the range of movement, in the muscle bulk, in the leg length. So asymmetry is a very useful, very objective sign that there's something going on which may be inflammatory. The next thing I would say is that most kids with juvenile arthritis actually continue to function remarkably well. It's very unusual for kids to completely refuse to weight bear when they have juvenile arthritis, as opposed to something like septic arthritis or a structural problem in their hip. Or so if you're seeing a child who refuses to weight bear, have your radar out for differential diagnoses. The one exception I would say to that is children that are in infancy or probably below 2 years, when they're really establishing their mobility, and they will often refuse to weight bear and want to be carried. But children beyond the age of being happily carried by their parents will rarely refuse to weight bear. Rheumatoid factor and anti-CCP antibodies are rarely positive in juvenile arthritis, only 2%, so don't be reassured if your patient has negative rheumatoid factor. And look hard at the fingers and toes for clues. So it's every toddler has got slightly different toes, every human's got slightly different toes, but toddlers often have sausage-like digits anyway. So I don't look at one foot and then look at the other. I look at big toe to big toe, second toe to second toe, third toe to third toe, comparing one side to the other, because as you can see in this picture here, this fourth toe could be a normal variant, or it could equally be dactylitis. And if you compare to the other side, you can really get a sense of whether it's likely to be pathologic. There's some psoriatic nail changes. In terms of lupus, particularly have your radar out in adolescent females, particularly those of non-Caucasian background. Take the discordant ESR and CRP, so high ESR, low CRP as a red flag. Look for the fixed malar rash, particularly with that fairly clear nasolabial sparing. Beware lupus in any child with unexplained cytopenias, particularly in an older child, including those who've been diagnosed with ITP. So the adolescent girl outside the classic ITP range who's been suddenly diagnosed with ITP out of the blue, you must check her ANA and serology for things like double-stranded DNA as well as complement. Looking at the palate, the hard palate is a very useful sign in the diagnosis of lupus, looking particularly for injection, ulceration and petechiae, and there will often be signs there that are easily missed but quite pathognomonic. Look for an ANA of 1 in 80 or stronger. The stronger the ANA, the more likely there is to be pathology there. And then with lupus, look for really subtle rashes, particularly to the hands and feet. So that can be flushing, it can be a reticular erythematous vasculitis type rash, particularly to the tips of the fingers and the peripheries of the palms and soles. Nail fold capillary changes, so using a ophthalmoscope, an otoscope, or a capillaroscope to look for things like dilatation, dropout, tortuosity, and you can see some pretty clear pictures of that on Google. Look for Raynaud's and look for arthritis, obviously, in the small joints. So here's some pictures of Raynaud's phenomenon. And then moving on to dermatomyositis. So really interesting condition, which has some once you've seen them, very classic changes, cutaneous changes. But having met literally hundreds of kids with dermatomyositis, I can think of hardly any that weren't at one stage before their diagnosis was confirmed, told that they had warts or eczema. Very, very classic to be told that Gottron's papules are warts, or that the extensor changes of dermatomyositis, so the erythema over the knees and elbows, is eczema, even though classically eczema is obviously flexural. So look for a malar rash, look for a heliotrope rash, a slightly purplish discoloration over the eyelids, sometimes can look eczematous. Look for Gottron's papules and beware any diagnosis of warts when there's great symmetry. Look for changes over the elbows, the knees, the shawl sign over the upper back, and the V sign over the anterior chest, which are related to sun exposure. It's obviously a photosensitive condition. Clarissa Pilkington, who was head of department at Great Ormond Street when I trained there, had a wonderful, incredibly useful sign that she taught to me and the other trainees, which I call the chin to chest sign. But essentially, if you, for example, over the telephone or in the emergency department, are asked to assess a child for dermatomyositis, the most useful thing you can do is lie them down flat on the bed and ask them to to flex their neck. Essentially, try to put their chin on their chest, and I'll show you a picture of that in a minute. Because it's very common for children with dermatomyositis to be upright, walking around, going to school, have no reported or observed weakness, and yet they have profound core weakness that is really only picked up if you specifically look for it. And that, for me, particularly if you're getting a telephone call about a kid that's got rashes or whatever symptoms and you think might be dermatomyositis, get them to lie them down flat on the bed and see if they can lift their head up. And if they can't, then be very suspicious of JDM or some other proximal myopathy. The other thing to say about JDM is that they very often have normal CK or only slightly elevated CK. So they tend not to have the ragingly high CK in the many thousands that you sometimes see in more adult disease. Often in the hundreds, sometimes in the low thousands. They can be higher, but I would be very suspicious of a child, and I would be very comprehensive in my workup if a child had a CK in the many, many thousands. And likewise, a child that has a normal CK can absolutely have JDM. Watch for AST and LDH. There's often subtle changes in those other muscle enzymes as well. And the other sign that can be useful, which you can see a little bit in this picture here, is what Clarissa Pilkington called raggedy cuticles. So in addition to the very subtle nail fold capillary changes, they have this cuticular overgrowth from the hyperemia, so the increased blood supply, and they just have raggedy kind of excoriated cuticles. So this is, I think this is probably Pilates handout or something similar, but it essentially demonstrates what I was talking about in the chin to chest sign. So you get the patient to lie down flat, and then you ask them to put their chin on their chest, and then try and put some resistance against it if they're able to do that. And children with dermatomyositis almost invariably are either unable to do that or unable to hold their neck up against resistance. So quick Cook's tour of vasculitis. Of course, there's classic labs that we look for in vasculitis: ANA, dsDNA, ENA, C3, C4, and antiphospholipid antibodies for lupus. ANCA, both immunofluorescence and also MPO and PR3, if you're thinking about ANCA vasculitis. HLA-B51 can be useful in Behçet's, though is not by any means always positive. Anti-GBM antibodies, glomerular basement membrane for Goodpasture syndrome. And always think of vasculitis as possibly a para-infectious or post-infectious phenomenon, including, of course, what we've seen over the last 2 or 3 years, which is MIS-C or PIMS-TS following on from COVID. Always check the renal sediment for activity, so blood cells, protein. And think about vasculitis in any patient where there's unexplained fever despite extensive investigations. If there's unexplained multi-system disease, of course, the vascular trunk extends throughout the body by necessity. If there's unexplained elevation in inflammatory markers, and particularly look at the blood pressure. And if you're seeing that kind of picture, always be sure to check the pulses, listen for bruits for Takayasu arteritis. So I've seen a number of patients in whom the presenting symptom is really very non-specific, so either fever of unknown origin with nothing else to find on examination, back pain and generalised malaise, but nothing much to find on examination. And you really need to, in these kids that seem to be hot and inflamed and you just can't pinpoint what it is, you really need to have Takayasu or a medium large vessel vasculitis on your radar. And of course, in the presence of mouth or genital ulcers, you must think of Behçet's. So this was a teenager that I was referred with biomechanical back pain, or back pain presumed biomechanical, who had no fever at all, but on probing, she had persistently raised, moderately raised inflammatory markers, ESR of 30-ish and CRP about 50, but she was hypertensive. And as you can see, when we did the angiography, she had this beating and stenosis, and she ended up having very significant aortic changes as part of her Takayasu arteritis, which is what accounted for her supposedly biomechanical back pain. So finally, when to think of something else? What are the red flags in paediatric rheumatic disease? So consider when there's non-articular pain, particularly bone pain, by which I generally mean diaphyseal pain. Consider when there's fever without raised inflammatory markers. That to me is always a red flag for malignancy. If there's raised LDH or if there's loss of weight, again, concern about malignancy. Pay attention to the blood count, particularly look for bicytopenia or pancytopenia, and look for an inflamed child, high SR, high CRP, but with normal platelets, which we would call a relative thrombocytopenia, and that can be a sign of malignancy, for example, a leukemia, when the child is inflamed from their malignancy and would normally have a thrombocytopenia, but in the presence of systemic inflammation, it pushes their platelets up into the normal range. Of course, beware night pain, and beware very severe pain, a child who's unable to walk, who's stopped walking. Most kids with rheumatic disease actually function pretty well. Beware monoarticular disease. Many kids, probably most kids that present with juvenile arthritis have monoarticular disease, but have unilateral disease. But if it's monoarticular disease and there's a single joint, yes, absolutely, it can still be juvenile arthritis, but just be very sure that you've ruled out structural stuff first. Look for infection, malignancy, Perthes, Sufis, PVNS, so pigmented villonodular synovitis. So if it's only in one joint, imaging is really important to make sure that you've excluded other factors, other potential contributing causes. And here's a classic X-ray of a SUFI, slipped upper femoral epiphysis, and the so-called ice cream on cone. And for SUFIs, of course, don't forget to do the frog leg view X-rays, otherwise you can miss it. So in summary, when to think of rheumatic disease in childhood? Probe the family history of autoimmunity and do be quite specific. Always be more suspicious in female patients, particularly adolescent patients and those of non-Caucasian backgrounds. Be alert to symptoms that are persistent and consistent. They keep happening over weeks to months, always in the same spot. Be alert to morning symptoms, to asymmetric symptoms, and to the triad of fever, rash, and arthritis. And of course, in any child where there's unexplained and persistent inflammation or fevers or multi-system disease. So thank you very much again to the organisers for the opportunity to present today. I really am very grateful, and I thank you all for your time. If you have any questions or feedback, I would very much welcome them, and it's rebecca.james2@health.qld.gov.au. So thank you very much.
That was brilliant. Thank you so much, Dr. James. Now, before I move on to the second talk, I would like to introduce Professor Iftikhar Ijaz, who has just recently joined us at this session. She's Professor of Pediatrics at King Edward Medical University, and she's also a pediatric nephrologist. And we also have now with us Professor Khwaja Amjad Hussain, who's working as Professor of Pediatrics and Services Institute of Medical Sciences. It's an honor to have you here, sir and ma'am. I would also like to request the participants who are joining us virtually to start posting your questions in the Q&A section so that we can compile them in time and present to the speakers. Now, moving on, the second talk of the session is going to be delivered by Dr. Somrat Vilayek. She's Chief of Rheumatology Division, Pediatric Department, Faculty of Medicine, Ramathi Bodhi Hospital, Mahidol University, Thailand, and she's going to present a talk on GIA titled, Is it GIA?
Good afternoon, ladies and gentlemen. My name is Somarat Pilayuk. I came from Faculty of Medicine, Rheumatic Hospital, Mahidol University. First of all, I would like to thank Pakistan Society for Rheumatology and APLA for inviting me to be speaker today. The topic I'm going to talk today is this juvenile idiopathic arthritis. The overview of my talk is JA classifications. I would like to share the case presentation with you and tips and learning points of each case. As we know that to diagnose juvenile idiopathic arthritis, the patient should have age less than 16 years and should have arthritis more than 6 weeks. And the most important one is the patient should be exclude other conditions, especially infection and malignancy before diagnosis. According to the ILA classification criteria, there are 7 subtypes of JA based on clinical manifestations. The first one is systemic JA, is the JA subtype that have systemic manifestation along with the arthritis. And if patient have less than 5 joint involvement, we call oligoarthritis. If patients have more than 5 joint involvement, we call polyarthritis, which include rheumatoid factor positive and negative. If the patients have enthesitis along with the arthritis, we call enthesitis-related arthritis or ERA. The ERA is quite similar to the ankylosing spondylitis in adult patients. So if the patient has psoriatic rash along with the arthritis, we call psoriatic arthritis. In some cases, patients can have arthritis along with dactylitis, pitting nails, or family history of psoriasis as well. If the patient do not fall into any category or fall more than one category, we put into undifferentiated arthritis. This figure will show you the frequency of each JA subtype in each region around the world. You can see that in Western countries, the oligoarthritis and rheumatoid factor negative polyarthritis are more common. Compared with the Southeast Asia, systemic JA and ERA are more common. So the case one that I would like to share with you, a 3-year-old girl who presented with fever and joint pain for 7 months. She presented with high-grade fever, rash on her trunk, lymphadenopathies. And at that time, she was diagnosed with incomplete Kawasaki. And she would receive IVIG 2 grams per kilo for 2 courses. The fever went down, but it returned again. Then, prednisolone 2 milligrams per kilo per day was given for a short period. She felt better at that time, but after discontinuation of the steroid, the fever, joint pain, and rash returned again. On her physical examination, she had mild pallor along with a high-grade fever, tachycardia, multiple lymphadenopathies, and myopathomegaly. She also had arthritis on both knees and right ankles, as shown in the pictures, and also had rash with no itching, and the rash usually came and went away with the fever, as shown in the pictures. And her CBC had mild anemia with the leukocytosis, with neutrophil predominate and thrombocytosis. She also had increased the ESR, but other lab are normal. At this point, do you think what is the most likely diagnosis? Refractory Kawasaki disease, or she has systemic JAA? According to ILA criteria, the patient who had arthritis with a fever more than 2 weeks, and these 2 weeks of fever, they require 3 days of quotidian fevers, plus one of the following below: evanescent rash, generalized lymphadenopathy, enlargement of liver or spleen, and serositis. If the patient fall into this category, they call systemic JA. So here is the typical fever pattern that we call quotidian fever. You can see that the single rise of fever to around 39 degrees, and it went down. The patients will get quite very sick when the fever went up, but when the fever went down, they quite get very well. And the fever came along with the rash and came along with the arthritis as well. So if the patient had rash, the rash usually comes and goes with the fever. It's discrete, erythematous macule in size and salmon pink color. You can see this color, and commonly in trunk and upper extremity. And when the rash goes away, it's leave no residue. When you apply pressure on the skin, the rash will go up. It's called Koebner phenomenon, and you can see in this point. The CBC will show marked leukocytosis with neutrophilia and high inflammatory markers with thrombocytosis and high ferritin level with anemia and inflammations. So the tips and learning point of this case: we should know what is the difference between systemic JA and Kawasaki disease. The two diseases is quite similar in clinical manifestations, but the quotidian fever is quite typical in systemic JA more than Kawasaki. And also, if the patient has salmon rash, come and goes along with the fever, and if the patient has persistent arthritis, do you think about systemic JA more than Kawasaki disease? But if the patients have coronary aneurysms, had polyungual peeling and edema of hand and feet, and all patients have a good response to IVIG, that's one you should think about Kawasaki disease. Whereas the systemic JA, we have good response to steroid, not IVIG. So case 2, a 6-year-old boy who presents with a joint pain for 6 months. So this boy had joint pain in multiple sites, west and veins. The pain usually occurred during the nighttime. No morning stiffness. He also had fever off and on along with joint pain and no weight loss. His CBC showed anemia and thrombocytosis and increased inflammatory markers with the iron deficiency anemia and ASO also negative. 4 days before admissions, he developed left knee pain and refused to walk because of the pain. He was treated with ibuprofen, and at that time, it's like a little bit better, and he started moving his leg again. But however, finally, he still refused to walk and developed left wrist pain. His CBC showed that the hematocrit was dropped to 24%, and the white blood cell count had lymphocyte predominate. So this picture is showing the arthritis that he had joint involvement. His mild swelling, limit range of motions, and he usually had increased the ESI and CRP as well because of the drop of the hematocrit quite rapidly. So we think that it's probably not the JA. So we suspect didn't he have malignancy? So we saw the peripheral blood smear and we saw some lymphoblasts. Finally, the bone marrow aspiration was performed with this boy and it showed acute lymphoblastic leukemia. So the MSK involvement in leukemia can range between 7 to 62%, depend on the literatures. Patient can come with a limb pain around 40%, following by bone pain, joint pain, or limping. The MSK involvement was far more frequent in acute lymphoblastic leukemia compared with the acute myeloblastic leukemia. Previous study tried to compare between the leukemia with MSK involvement and leukemia without MSK involvement. So in around 1,000 of childhood leukemia, they found around 8% that having MSK involvement. And among this group, 95% had joint pain and 33% had bone pain. Among patients with joint pain, around 85% had arthritis and 14% had arthralgia. And the most common joint pattern involvements is polyarticular, followed by oligoarticular and monoarticular. And the joint involvement is usually large joint, ankles, knees, and elbows. And around 82% also had radiologic abnormalities. 1/3 of these studies, they found a misdiagnosis, and half of them diagnosed with the JA. So the patients who were diagnosed also had longer duration from onset of disease to diagnose with leukemia, which is around 60 days compared with the correct diagnosis with 30 days. So if they compare the leukemia patient with MSK involvement, this group of patients usually had higher hemoglobin level and platelet count, and lower white blood cell count and peripheral blast count compared with the leukemia patient without MSK involvement. Also, patients with MSK involvement, 17% had absence of peripheral blood cells, whereas the other group is only 10%. And median LDH was slightly lower in MSK involvement. Did you see this? So that's why it's quite difficult to diagnose patients who present with the MSK involvement. So in this study, they classify patients into 3 groups. The one is ALL, non-systemic JA, and systemic JA. As we know, the systemic JA is quite similar to the ALL, and it's very difficult to differentiate. So you have to know that what is the difference between 2 groups of disease. The ALL patients usually have low hemoglobin level, low platelet count, and low white blood cell count compared to systemic JA. And the neutrophil count usually higher in systemic JA, whereas the leukemia usually have lymphocyte predominate. And the median LDH usually be higher in ALL compared to systemic JA and non-systemic JA. But uric acid are not different much among 3 groups. So the tips and learning points of this case. If the patient presents with the morning stiffness or morning pain, it could be JA, monoid malignancy. But if patient presents with the night pain, and especially the pain wake him up at night or night awakening pain, you should think about malignancy first. Malignancy usually has severe pain, no response to NSAIDs, or only partial response to NSAIDs. In some patients, they have no sign of inflammation at all because it's bone pain. If you see from the CBC, the malignancy patient, we have leukopenia, lymphocyte predominate, and thrombocytopenia. And this patient usually looks sick compared to the JA. So the last case is case 3, a 2-year-old girl that presented with a limping for 6 weeks. So this girl complained of right leg pain and refused to walk. And a week later, she had high-grade fever for 3 days. She took ibuprofen, and fever and pain was slightly better, but still refused to walk for no reasons. So her CBC showed anemia, leukocytosis with neutrophil predominate, increased CRP, but hemoculture no growth. A week after that, the pain was worsening. She was admitted at the hospital nearby. She was treated with ceftriaxone and hydrocortisone, and she markedly improved. Fever has gone, and she started to walk again. But a week after that, her pain returned, and she could not walk. And at that time, I stopped all the medications and did the blood test MMI again. Her blood test at our hospital is quite nearly normal. Hemoculture still no growth. CBC did not show anything. She had iron deficiency anemia, that's all. But the MRI is quite interesting. She had myasthenitis, right side more than left side. She also had enthesitis. She had sarcoileitis and also have myositis in many muscles. So at that time, the radiologist suggests about the ERA because the enthesitis-related arthritis, patient can have arthritis, enthesitis, and sarcoileitis as this group. And patients can have HLA-B27 positive family history of HLA-B27 and telluritis. And patients usually be male, aged older than 6 years old. This girl did not have HLA-B27 positive. She didn't have family history of HLA-B27. She had only arthritis, enthesitis, and sarcoileitis. So the ERA manifestations, 1/3, you can see the patient can come with the sarcoileitis, hip arthritis, and enthesitis. And when you follow up patients, it can increase to 60%. But if you see the demographic data of ERA, the age at onset is around 10 years and mostly male predominance, which is quite weird. Like this case is a girl and 2 years old girl. So I think it's unlikely to be ERA in my opinion. I'm thinking about infective sarcoileitis, which occur in around 1.5% of all joint infections. And the Staph aureus is the most common organism in this disease. However, around 50% of patients, they cannot find any organism in hemoculture, especially in younger children, because they think that it might be infected by Klebsiella kinkerae. This kind of germ usually difficult to grow in culture media, often poor either from bone joint fluid or blood. And there are two main clinical forms of infective sarcoileitis: in adolescent, young adult, and in infantile, less than 48 months. The patient usually present with limping and buttock pain without fever and early of the disease. And it's quite difficult to diagnose, especially in young children like this case, who cannot explain symptoms, and they will present with refusal to walk or bear weight. The patient can have no fever or low-grade fever with mild symptoms, with general well conditions. This is the MRI of these patients. At diagnosis, you can see that the inflammation is around here. And at 1 month after cephalexin treatment, it's slightly better. And at 3 months, it's nearly normal. So we did not treat patient with steroid. We treat only with antibiotics, and she seemed to be better. She can run and she can walk. So and at that time, we think about Klebsiella kinkerae arthritis, which is usually affect previous healthy children aged less than 4 years. If it happened in older children and adults, those populations usually have other underlying conditions. Klebsiella kinkerae arthritis usually affect the large joint, include knee, ankle, and hip joint over 80% of cases. However, it can found in other joints as well. For example, the sarcoileic joint in this case, like this case. Because of my clinical presentation of Klebsiella kinkerae, when infected hip joint, some people might be misdiagnosed as transient synovitis of hip. So the tips and learning point in this case, the ERA usually affect male patients aged older than 6 years. So which is quite different in girl and aged around 2 years, like our case, so unlikely. Number 2, the infections cause more severe inflammation than autoimmune disease. Like you can see the inflammation of the muscle around sarcoileic joint in this case in an MRI, compared with the ERA that affect only the joint. And most ERA patients do not present with high-grade fever. And if patient present with a high-grade fever with buttock pain, thinking of infection first. So the take-home message of my talk today, infections and malignancy should be excluded before JA diagnosis, as you see in our case. If patients present with atypical JA manifestation, please consider other disease. So if the patient presents with a night pain and moderate to severe anemia, thinking of malignancy first. And if you treat patient with the first conditions and it results in a worsening or recurrence, please seek another disease. So sometimes things that look alike are different. Hope that you enjoy my talk. Thank you for your attention.
Thank you so much, Dr. Somrat. That was brilliant. Now we move on to the last, but definitely not the least, third talk of the session, which is going to be delivered by Dr. Tashvi Arkachaisri, who is Head and Senior Consultant, Rheumatology and Immunology Sciences, KK Women and Children's Hospital, Singapore. He is going to deliver a talk on latest treatment guidelines of GIA.
Good morning, everyone. I would like to thank the organizer for having me as part of the second PSR, Pediatric Rheumatology Review course. In the next 20 minutes, I will cover the latest treatment guidelines for juvenile idiopathic arthritis or JIA. I have nothing to disclose. We will discuss the latest JIA treatment guidelines and recommendations developed by the American College of Rheumatology 2019 and 2021. Other countries' guidelines for GIA treatment has not been updated, and the ACR guideline and recommendation was used worldwide. If we have time at the end, we will talk about a treatment strategy. I want to remind you that these guidelines mean to be a guidance. You still have to consider your patient on an individual circumstance. And these guidelines subject to intermittent revision when the new drugs come into the market and get approved. They are not intended to dictate payment or insurance decisions. As I mentioned, many drugs lately has been approved to be used for the treatment of juvenile idiopathic arthritis, especially polyarticular form. The latest one would be the secukinumab, approved for ERA and psoriatic arthritis, just December 2021. So tofacitinib, which is the first JAK inhibitor, also approved for polyarthritis since September 2020. However, the guideline in 2021 still not mentioned it. So let's get familiar with the term and definitions. The guideline developed to use for the patient phenotypes, meaning polyarthritis means 5 joints or more involvement, regardless what JIA categories classified by the ILA criteria. Okay, so it may include extended oligo, ERA, psoriatic arthritis, and differentiated arthritis. Risk factor that we will use will include positive rheumatoid factors or anti-CCP or presence of joint damage. And we will use the CJADAS 10 as the disease activity measures. Definition for low disease activity, meaning that you have the CJADAS score 10. CJADAS 10 score 2.5 or less and 1 or more joint involved. Moderate and high disease activity classified together, meaning that you have CJADAS 10 more than 2.5. Sequelitis and enthesitis population the same. Look at phenotype. Active sequelitis. Other than the patient-reported symptoms, you should have the MRI to support active sequelitis. Active enthesitis, use the physical exam for swelling or tenderness at the enthesis area. Okay. Two recommendation. One classified as strong recommendation, meaning that the course of action would apply to all or almost all of the patient. conditional recommendation may apply to majority of the patient, and it was recommended that you have to do the shared decision making, discuss with your patient and families, and it's preference sensitive. So individualized for each patient is very important. So we're going to go through the polyarthritis. The table I will give you the principle, and then we go to the algorithm for subsequent treatment. Okay, 2019 polyarthritis NSAID is not initial treatment. It can be used only as adjunct therapy. The conventional DMARD especially recommend methotrexate in the subcutaneous injection form as an initial treatment for all polyarthritis patients. Glucocorticoids, whether you use it locally as an injection or oral or IV, is used as bridging therapy, as short as possible, as low dose as possible, and the first 3 months only, or less than 3 months, especially in patients with limitation of mobility or significant symptoms. So they strongly recommend against adding chronic low dose PO glucocorticoid in any circumstance. See, so I mentioned already that they recommend a combination, meaning that you start methotrexate. If methotrexate fails, then you add biologics. I will not touch this PT and OT again, regardless what kind of arthritis. It's conditionally recommended to put PT and OT for all the patients. So let's go to the algorithm. As I mentioned, polyarthritis, then you start with methotrexate, especially subcutaneous methotrexate for the increased bioavailability, especially at the higher dose at 10 to 15 or more milligram per meter square. Okay, and then you use NSAID as adjunct therapy. You can add steroid as bridging therapy at this point. After 3 months, if the patient has low disease activity, they still recommend you to control the disease by giving IA, intra-articular steroid. And the intra-articular steroid that recommended would be triamcinolone hexacetonide, and I hope that everyone knows the reason. If the patient has moderate or high disease activity, then you would add biologics, and it go into this order: anti-TNF first. Okay, they would not recommend triple DMARD or change to the second conventional synthetic DMARD. Fail methotrexate, go to biologics, especially anti-TNF. After a good duration of trial, they did not say how long. Usually the rule of thumb is about 3 months. If the patient has low disease activity, then you use steroid, or you increase the dose of DMARD, or you add biologics in that matter. But moderate to high, meaning that you fail, or we call primary anti-TNF failure, then you go to the next one would be abatacept. Okay, and then if that failed, then you move to tocilizumab. Okay, if the secondary failure, meaning anti-TNF worked before, and then follow up the patient for a while, and then still the patient flare on the full dose of anti-TNF, then that's called secondary failure. If you are in the facility, this is my opinion, in the facility that you can send anti-drug antibody, then please do so. Otherwise, it's called secondary failure. Then you may be able to use the second anti-TNF before you change to another class. So that's for polyarthritis. Now we go to sacroiliitis. Strongly recommend against the use of methotrexate in any route. Bridging therapy is recommended, especially in the patient has disability, and the same rules, less than 3 months. You can use IA if you can inject the sacroiliac joint. Okay, methotrexate use is the same. Subcutaneous injection is recommended. They also recommend that you can use NSAID. Okay, enthesitis. Actually, the use of enthesitis is the same as sacroiliitis. You would not use methotrexate as an initial therapy. You will use NSAID for variation of the period. But normally, if the patient on NSAID still in pain or still disabled, then you would upgrade to methotrexate. And they recommend methotrexate or sulfasalazine for the enthesitis. As for the sequelitis, only biologics. Then if that's still not working, then you can add oral glucocorticoid as a bridging therapy. Okay. So now we go to the 2021 oligoarthritis as a significant change. In any case, a trial of NSAID still recommended, and glucocorticoid can be used, and triamcinolone hexacetonide is the one that recommended for the intraarticular steroid injection. Oral steroid can be adjunct therapy. Okay. Conventional synthetic DMARD strongly recommend if there's inadequate response. So I will go through this next slide when we talk about the algorithm. Now, if you have the risk factor for poor outcome, this means you have involvement of the ankle, wrist, hip, sacroiliac joints, TMJ, or erosive disease or enthesitis. Then you may want to move or escalate the treatment sooner. Okay, so for the patient who has oligoarthritis, go ahead and use NSAID or intraarticular steroid injection. If that's still not working, then you go to DMARD, especially methotrexate. If that's still not working, then you go with biologics. TMJ, more or less the same as polyarthritis. They recommend you to use methotrexate as initial treatment, NSAID and intraarticular corticosteroid or even oral steroid used as adjunct or bridging therapy. Okay, and if that fails, then you still go with the biologics. Okay, there's no preferred agent because evidence for specifically TMJ is lacking at this moment. However, anti-TNF still what we use. Okay, systemic GIA without MAS. Now for systemic onset GIA, regardless whether you have active arthritis or not, regardless whether you have MAS or without MAS, the initial therapy is not methotrexate anymore. You will use anti-IL-1 or anti-IL-6. The difference from the 2013 is that you can use either IL-1 or IL-6 inhibitor, depend on where you are. Okay, and NSAIDs can use as a monotherapy, especially in a setting of without MAS. And then you just give a limitation of the time. If that's still not control systemic or arthritis disease, then you go with the anti-IL-1 or anti-IL-6. Okay, so let's go to the algorithm here. So in systemic GIA, if no MAS, then the initial therapy is still anti-IL-1 and IL-6. And then you can use, you can try with the NSAID for the short course, or you can go ahead with the anti-IL-1, anti-IL-6. If it's still not respond, if you use IL-1, then you use IL-6. If you use IL-6, then you use IL-1. Okay. If you has MAS, then go ahead with anti-IL-1, anti-IL-6, and use systemic glucocorticoids. We usually use a pulse methylprednisolone in that matters as a bridging or adjunct therapy. Okay. Now, if you have arthritis, then methotrexate may be used and in that setting. Okay. And then after that, if every single thing is under control, then they recommend that you stop the steroid, especially when you don't have the systemic symptoms. Steroid should be stopped as soon as possible. And then after that would be taper or stop the biologic DMARD. So non-pharmacologic therapy, I just want to highlight that the supplement or the diet is not recommended. And for the drug monitoring, we have been doing it. Early, when you just start the first 1 and 2 months, you have to monitor a full blood count, liver function sooner. And after that, every 3 to 4 months. Only one over here would be abatacept, that you don't need to monitor anything. That just a little bit surprised me. You monitor the lipid panels if the patient on tofacitinib or tocilizumab. Okay, just for the surveillance, nothing changed. COVID-19 vaccination has not been put in place in any guideline. Imaging study, X-ray is not recommended to use for screening or anything. At least you use it to assess the damage. Otherwise, there's no role. Okay, I have only 5.5 minutes. I'm gonna go through it fast because this is up and coming. Okay, this was done by the CARA group in North America. Look at the high dose of the biologics. So if standard dose not working, whether high dose is okay or not. Actually at the 50 sites in North America, you look at that 20% of the physician will use the higher dose, meaning more than 40% of the standard dose. And infliximab is the first one that they use, almost 50% of the anti-TNF. The second one would be certolizumab, which we have not been using commonly, and then adalimumab. Okay, and then as I put in here, there's no significant difference in the outcome if you compare the high dose group or you switch the biologic. You switch the biologics. So, and then the adverse reaction also not that different. Okay, but it actually improve outcome if you compare the high dose biologics compared to the no change. Actually, number of the active joint is actually much better compared to no change. So high dose of the biologic, especially anti-TNF, you can try. If in your setting that you don't have much choice of the biologics or other things to use, then you may want to increase it and then see whether that helps your patient or not. And then later on, when the disease is under control, then you drop the dose. Okay. Another paper would be the starting time of the biologics. The consensus treatment strategy for the CARA, they look at 3 strategies. Okay. The first one is a step up that we have been using. You use methotrexate, and if that's still not working, then you add etanercept. You are allowed to use steroid in any time. Early combination means you go ahead and start with combination of methotrexate and anti-TNF. And then another group would be you just use anti-TNF as a first line. As you can see, early combination actually get the improved disease outcome at 12 months, more than another 2 group. And then if you can see at 12 months, look at the JADAS-10 as an outcome measure. A step-up group and the biologic first does not make any difference. Okay? And then the adverse reaction also not different. I put this as an abstract. In the past, in the recent EULA meeting, how to win the anti-TNF. So we have about 10 or 11 year data, and this kind of data can come from only cohort observation, a study with a long-term follow-up. Okay, we have 2 strategies for weaning of the anti-TNF. One is a short, meaning that if I use adalimumab every 2 weeks, when the patient reach the remission on medication, mean inactive disease on the full dose of anti-TNF for 6 months, then we start to wean. And the only one step weaning is from every 2 weeks or to every 4 weeks for 6 months and then stop. Another long weaning, meaning from every 2 weeks go to every 4 weeks, 3 cycles, every 6 weeks, 3 cycles, 8 weeks, 10 weeks, 12 weeks, 3 cycles. Total time that you use this is almost 2 years. And then the outcome would be look at the proportion of the patient who flare during and after discontinue the anti-TNF. Okay, we have 57 out of the 107 patient, 57 on the short and 50 patient on long. Okay, as you look at the long weaning group, during the weaning, 48 patients or 24 of them would flare. Okay, 24 of them would flare during the weaning. Okay, and the duration of flare after anti-TNF weaning is about 7 months. Okay, and then if you look at the time, look at the flare after discontinue, 35 out of 57 in the short and 16 out of 50 of the long is flare. And the time to flare after you stop at the end of the weaning, meaning at the end of the 6 months and at the end of these 2 years, time to flare is not different. It's about 7 months. So I just gonna simplify to you that the rate incident of the flare episodes per 1,000 person months is not that different. Actually, the long weaning group actually has a little higher, but it's not statistically significant. However, when you have the long weaning, when you go into the every 4 to 6 weeks, that's when the patient start to flare. So meaning that even you use the long, there would be one small dose that can hold the patient to prevent the flare. So with using the short and the long, it does not make difference in terms of the duration of the anti-TNF to flare. So I don't think that it makes difference. So this is just to summarize what I have been talking about in the past 20 minutes. Glucocorticoid of any route used as the bridging therapy only. Anti-IL-1, anti-IL-6 is recommended as the first line of systemic GAA, whether you have the joint or no joint. Okay, anti-TNF would be the first line in sacroiliitis and enthesitis after you fail NSAID. TMJ use MTX before you consider anti-TNF like polyarthritis. None of the guidelines talk about duration of maintenance of therapy after the disease is into under control or inactive disease, or how to wean it or when to wean. Coming soon would be probably, I can tell you that they will update about the JAK inhibitor and anti-IL-17. Radiography not used to assess disease activity. Okay, COVID-19 vaccination is not included. Okay, high dose anti-TNF patient actually has a place to use if you need to do it, because it actually increased the patient efficacy in certain group of the patient. It decreased the joint count, and the side effect is not that different. And then for the strategy of the use, if you can, you use early combination. At 3 months and 6 months, you can decrease the use of the steroid and control the disease maybe sooner. But at 12 months, I can tell you that you use biologic first or you step up, it may not do anything different. Okay, obviously early use of biologics monotherapy will bring the disease in inactive disease sooner by 3 months or 6 months even, and use steroid a little bit less. Okay, weaning of anti-TNF, as I showed the result, the risk of flare is not different. Time to flare after anti-TNF discontinuation also not different. With this, I would like to thank my group, both the clinical science and the basic science or translational research lab science that has been supporting me for the past decades. Thank you everyone for your attention. I know that I speak quite fast. We will have the question and answer, I think, at the next session, and then I'm happy to take any comment or actually take question. Thank you very much.
Thank you very much, Dr. Tashvi. That was a very elaborative talk on treatment guidelines. Now, before heading towards question and answer session, I would like to announce that the links for MCQs and feedback forms have been shared in the chat box kindly fill those so that you can claim your CME certificates. Shall I begin with the question answer session? Do we have the speakers online with us? All right.
I'm so sorry. I just want to thank each one of you. Thank you, Beck, Tash, Som, for fantastic presentations. And so we look forward to the Q&A with you. I would like to request our chairs and guests of honor to please come and join the expert panel. Rebecca, would you like to come? You're okay there.
You're okay there.
Would you like to join the panel? Yeah. So we'll start the Q&A.
So the first question is for Dr. James. So the question is, why CRP is high in lupus patients who have arthritis? Is there any explanation for that?
Wonderful question, and I've got no idea of the answer. It's always something that I've just swallowed and not questioned, but I'm sure one of my panelists who's cleverer than I am might be able to answer that. So I'm sorry, I don't know the answer.
Would anyone else like to comment on that? Why is CRP high in lupus patients who have a flare of arthritis?
Should we answer from the
Yes, you
panelists?
can. You can. If you have a comment, you can.
We don't know the exact reason for it, but it has been seen to be associated with active arthritis.
Usually CRP is normal in cases of lupus, but when there is serositis or infection, CRP is also increased because this is also an inflammatory marker.
Even in arthritis, it is raised?
Yes,
so
even in arthritis, it can be increased.
It can be raised.
Especially serositis ke saath.
All right. So the next question is for Dr. Somrath. So while talking about leukemia as a mimic of GIA, you shared that more than 80 patients had radiographic features. So which features were you exactly talking about? Can you elaborate on that, please?
The malignancy? Sorry, do you hear me?
Patients having leukemia and mimicking GIA.
Hear me? Do you hear me?
Yes, I can.
Okay.
Can you hear me?
I'd like to know what is the abnormality of the radiography, radiological finding in malignancy, right? Hello?
Yeah, can you hear me, please?
Okay, it's osteopenia, osteolytic lesions, leukemic band, something like that.
Okay.
Hear me? Sorry.
Yes, we can hear you.
We can hear you.
We can hear you.
We can hear you. We can hear you. Sorry.
We've understood what you're saying is osteopenia and lymphocytic band, ALL bands, right? I think the question was also, do you actually see synovitis, or it's basically the bone that has expanded?
Ischemic arthritis, it could be like you can see synovitis as well, but if the bone infiltration, so sometimes the patient do not have synovitis, so it depends. Depends like when patient present with the joint pain and do not present with the arthritis or any swelling, you do not see synovitis. You see only the bone abnormalities. But if the patient present with the arthritis, you can see synovitis as well.
Samia wants to say
and
something.
In cases of systemic onset GIA mixed with malignancy or finally diagnosed as leukemia, they may have sometimes even synovitis on their x-rays. And the most other striking feature is lytic lesions. You can find the lytic lesion on the x-ray, which is hallmark of malignancy.
Okay, and
Yes, moving on to the next question. It is also for, again, for Dr. Somrat. So is it possible to have systemic onset GIA with normal serum ferritin levels? And if yes, then how often do you see this in your clinical practice?
I did not routinely check the ferritin level in every cases, but usually in systemic GA patients, they have high ferritin level. I rarely see it's normal for the ferritin level in active systemic GA, but in lupus patients with macrophage activation syndrome, that's one can have normal ferritin levels. I don't know that other panelists see the normal ferritin level or not, but in my experience, I did not see the normal levels.
No, we check it fairly routinely in your diagnoses of systemic onset, and I don't recall seeing one that has a normal ferritin level. There's quite a significant variability depending on the extent to which they're tipping towards that MAS picture. But I have to say I can't recall seeing someone with systemic onset arthritis that has completely normal ferritin.
Right.
It's
so,
hello? Hello?
Yep, we can hear
yes,
you.
Dr. Tash,
Oh,
we
okay.
can hear you. Would
So,
you like to?
yeah, same with Rebecca just said, ferritin is one of the acute phase reactant. So if you see other acute phase, especially CRP or other CRP increase or ESI increase, ferritin usually increase as well. Okay. But then obviously if you look at the patient that has less active, even though they have some active arthritis, but systemic symptom is not there much, then the ferritin may be not that high or even normalized. So it's go with your systemic inflammatory activity. That's why at presentation, I can tell you almost everyone, I think probably everyone, like Rebecca just said, will be high.
All right. So the next question is for all the three panelists, really. The question is, what are the preferred treatment options in enthesitis-related GIA as far as safety in kids is concerned? What is the role of biologics and their safety? Can you share your own personal experiences with us, please?
Okay, I will go first then since I cover the management. I actually give the organizer two versions and they use the wrong version, so I make some mistake there. So like psychoileitis, enthesitis, methotrexate, even in my experience and also other people around the world, it does not work that way. Okay, so after NSAID trial, if it's still not better, tenderness or swelling still there, people usually jump to anti-TNF. Yeah.
So in my experience, it depends on the HLA-B27. If the patient had HLA-B27 positive, half of them refractory to the DMARD. So I will go with the methotrexate, sulfasalazines, and finally I have to start anti-TNF agents. It's quite respond very well. But in case of HLA-B27 negative, some patients is around 10%. Patients receiving sulfasalazines and some of them respond, but not much, around 10% in my cohort studies.
So this is, this is for patients without peripheral arthritis and just sacroiliitis. They do respond to methotrexate. Is that correct? If they are non-HLA-B27, 10% with sacroiliitis.
Yes,
okay.
without sacroiliitis, yes. Okay. So I mean, it's only enthesitis or arthritis. But if patient have sacroiliitis, it will end up with the anti-TNF.
Yeah, then they'll have to go to anti-TNF. So sacroiliitis, you have to give anti-TNF, yeah.
Yes, yes, yes.
Yeah.
So the next question is for Dr. Tashby. So triamcinolone hexacetonide is not available in Pakistan. We have triamcinolone acetate or methylprednisolone. Which one would you prefer out of these two for intra-articular injection in children?
I have to admit that my experience with those two is very limited, but I know for sure if you have only one or two acetone, half-life will be very short. So you end up have to double the dose, then you increase the volume, and that has a high risk of steroid that you inject leaking out of the joint capsule. And those are the side effects that you get from skin atrophy, from fat atrophy, or even weakening of the ligament that get in touch with your steroid. So that is the reason. So we try not to give more volume, but if you have no choice, I think I have heard that methylprednisolone injection or even dexamethasone may be a little bit better than just acetonide.
All right.
Adult people, usually I can give you that answer. Yeah.
Right. So the next question is for Dr. James. How often do you see children with autoinflammatory disorders, and which are the few commonest ones that you see?
Yeah, look, I think the challenge with autoinflammatory disorders is always in picking out the children that have true autoinflammation as opposed to other causes for recurrent fever, including what I once saw described quite conveniently on the Ped Rheumatology list service. Somebody called it SURF, S-U-R-F, Syndrome of Unexplained Recurrent Fever. And that account, which is children that have recurrent fever with no underlying diagnosis found, but tend to be healthy, well kids. And that, I have to say, is the bulk of the children that I see referred to my clinic as query autoinflammation. They tend to be aged sort of 2 to about 6. They are well children who are growing well, that seem to have almost an exaggerated response to viral infections. I describe it to their parents as a twitchy immune system, but that resolves when they hit about sort of school age 5, 6, 7-ish, and it tends to fade out. And those children tend just to have recurrent fevers, or sometimes fevers without periodicity, without any sort of clockwork periodicity to their presentation, sometimes with some soft infective symptoms, maybe a bit of a snotty nose. And I think those are children who are just maturing their immune system. So that's the bulk of the kids that are referred to my clinic as autoinflammatory. The ones who have a true autoinflammatory disease are much less common, much rarer. And when I worked at Great Ormond Street with Paul Brogan, he was very meticulous about drawing a distinction between those two groups, or between groups that have other causes for their fevers, undiagnosed infection or so forth. So the commonest, I think it would depend to some extent on the ethnicity of your population. The commonest one that we would see in Australia is PFAPA. I think FMF as well, depending on the, as I say, the ethnicity of the population that you serve. But they would be the most common. The monogenic ones, things like TRAPS and CAPS and HIDs, are much less common. They're more satisfying in a way because they often respond to specific biologic treatment. But I do think that you have to be very cautious about not overdiagnosing autoinflammatory conditions, in my personal opinion. I think it's easy to do, and taking a really clear history, making sure there's absolutely no correlation with infective symptoms. And to be honest, I take a fairly pragmatic approach, and I am quite reassured by a child who is growing well with minimal associated symptoms, as long as they don't have terrible mucositis, terrible intercurrent rashes, hepatosplenomegaly, lymphadenopathy. Obviously that's all red flags. But in a child who otherwise is spiking fevers, is growing well, they're functioning well, they're attending school, I tend to take a sit back and wait kind of approach. And for the most part, these kids seem to just have a kind of a maturational, it's a maturing process of their immune system. And when they hit about 5 or 6 or 7, it all seems to settle down. And the general pattern is I see them when they're 2 or 3 or 4, and they're happening very frequently. They're very problematic to the family because the parents have to take a lot of time off work and the child's out of kindergarten or daycare, but then they gradually become less and less frequent and they peter out over time. So the true autoinflammatory conditions that are lifelong problematic, with risk of amyloidosis, etc., are much less common. Though I would always be more alert in a patient with an ethnic risk, or where there's consanguinity in the family background.
So we have one more question for Dr. Somrath. How can one differentiate on MRI of sacroiliac joints, whether it is infective sacroiliitis or whether it is inflammatory sacroiliitis? Are there any distinguishing features?
It's a good question. Actually, it's quite difficult because it will show like the osteitis on the sacroiliac joint is the same. But in the case that I share with you, the inflammations of the muscle around the joint is very much inflammations, and because of the patient's age group and they're females and they have high fever. So I combine everything together. So that's why I think that is unlikely to be the ERA patients. But if you see only sarcoiditis, it's quite difficult to differentiate between infection and inflammations. But in this case, it's quite, there are many obvious findings that point to the infections.
All right, thank you.
I have a question. Thank you for very exciting and excellent talks by all three speakers. What is your experience about developing malignancies after so many biologics being given nowadays? Is there any longitudinal data available?
We can start with anyone.
I can address that. Actually, when I was in the US, the KERA group already aware of anti-TNF and association with malignancy, especially lymphoma, actually lymphoproliferative disease. And then look at the Medicaid data that involve 5-digit number of the patient. And the finding interesting, actually. Number one, JIA itself has cancer risk already, more than general population. When you use methotrexate and control the disease, then your cancer risk drop. And if you even add in anti-TNF in, the cancer even less. So that is one evidence. So the US has longitudinal data and has a big data that to support. Number two, many pediatric rheumatologists around the world, I don't think anyone actually experienced that the patient get lymphoproliferative disease or any cancer later on. So the key here is still underlying disease can cause cancer. Control the disease well will make disability goes away or you prevent the disability. Patient development in terms of motor and growth is well, and the cancer risk should be lower with treatment. So that's my intake for that.
Dr. James, would you like to add anything on this?
The only thing I'll add is that I just included two in the chat to, I've included host and panelists. Perhaps you can distribute that afterwards. But there's two very nice articles that summarise and address this issue exactly, just as Som said. We always, in Australia, we have very high rates of skin cancer, obviously. And so we always caution patients to be who are immune suppressed, to be particularly conscious about UV protection, but that's as much environmental as it is about their immune suppression. I think my understanding when I last looked at the literature, which admittedly was probably 4 or 5 years ago, was that the agent that was the immune suppressive agent that was most associated with malignancy was azathioprine, which we don't use a lot of in pediatric rheumatology, but that was associated with a number of malignancies, including cervical cancer in women. So important to get HPV vaccine for patients who are on azathioprine.
Yeah, the data come from IBD literature a lot in terms of the cancer with anti-TNF, I think last decade. Yeah, and ASA is one of them, more than methotrexate actually for some reason. The majority of them actually use ASA in combination, that kind of things.
So, in a nutshell, you need to control the disease, control the inflammation. We do not have any solid data. And the only one drug probably is azathioprine, with which possibly you need to maybe keep that in mind and monitor.
Mm-hmm.
And Laura, you would agree with that as well? Okay.
I think it's always worth, the children that develop autoimmune disease have something about their immune system that's different to everybody else, and I think it's always important to remain vigilant to the possibility of malignancy by virtue of their whatever is going on in their immune system. But I think we can be much more reassured about the medications that we use than we could 5 or 10 or 20 years ago, for sure.
Right. There's one more question for Dr. Tashvi. So in patients with JIA who are not responding to first-line DMARDs, would you directly go to tofacitinib rather than going on to anti-TNFs? Because parents of patients often prefer pills over injections.
Well, that is one thing, but in Singapore, even this is considered a developed country. The money still matters. And tofacitinib does not have biosimilar, does not have any other company make it. So one pills here is about, one day is about 55 Sing dollars. So you can calculate. Compared to adalimumab, at this moment is much cheaper. Well, the data is more on anti-TNF compared to the JAK inhibitor at this moment. So if the patient really insists because they cannot take the injection, I'm okay to use tofacitinib and have used in Singapore actually. And it does not, it actually work, okay? But it just, we have the financial constraint that we need to consider. And if you want about the safety, tofacitinib and lipid is one thing. Anti-TNF is quite safe to me, and we have a long data. I mean, long safety profile, almost 20 years already that we use.
We've just recently had tofacitinib introduced actually. So a lot of, because we don't have that many biosimilars for injectable biologics, so the cost differential isn't that great sometimes. So, but I understand you've all had good experience with tofacitinib in children, Som and Beck and Tash and Laura. You've all used tofacitinib and reasonably good.
I have to say, yeah, I have to say we've used it more for, I've got a few JDM patients who are on tofacitinib, and we're just starting to roll it out with JIA. Look, it does seem to be a very promising drug. The data in adults does suggest that for those over, I think the cutoff is 50 or 55, there is an increased risk of cardiovascular events and malignancies. And we do have to be mindful that even though the data on other biologics has been reassuring, we don't have long-term data in children, and we don't know what early exposure to these drugs does. So I always go for the knowns before I reach for the unknowns. But I have to say, for the patients that are on it, it's been useful, and particularly for some JDM patients, dermatomyositis patients.
It's basically you have more long-term safety data on what's already been used as compared to tofa, but nothing to suggest other than the cardiovascular issues and all. Yeah.
I will add though, if oral versus injectable is an issue, we use a lot of combined methotrexate hydroxychloroquine because it increases the area under the curve of the methotrexate so that the two work in conjunction. So using methotrexate combined with hydroxychloroquine approximates subcutaneous injection of methotrexate. So if you have a patient where injectable forms like injectable methotrexate is not available or is difficult, combining oral methotrexate with oral hydroxychloroquine is a very nice alternative that works well. And so does splitting the methotrexate dose over about 12 hours. So instead of giving 20 milligrams per day, giving 10 milligrams, say, on a Friday night and 10 milligrams on the Saturday morning is also a useful strategy.
We still have some more questions which we will be posting to you, and because we're running out of time now. I just want to thank three of you so much for your wonderful presentations and to be here, online with us. If there's anything you want to add, you're welcome. Otherwise, we will be sending you the questions to be answered later. I am going to ask our expert panel for any comments or questions that they would like to, put forth to these speakers or generally. So, starting from Professor Iftikhar.
Thank you. It was a very elaborative and comprehensive presentations, and they have addressed almost issues that were related, especially with the treatment and the hazards that we foresee, or the limitations which we face in our part of the world where drugs are not available or the choices are limited. I think it was, for my part, I think it's one as an excellent presentation, and Dr. Samia, I prefer would be putting up better questions as it's a related field. We come across kids and the problems are there regarding the preference for treatment and the cost, especially in our part of the world, the cost matters a lot.
Gee, I just want to mention Arthritis Care Foundation, which is a foundation of which I and Professor Nigat, Professor Ahmed, and actually most of our faculty is a member. We sort of have been with it and, started like almost 20 years ago, but it's been working, how should I say it, probably been registered after 2010. And we do all of these. So we are conducting free clinics. We're able to, through the foundation, subsidize medicines, either free of cost or co-pay or whatever, including biologics. And some joint replacements have been funded, and also funding training scholarships for fellows as well. So that is one thing. And then, in the loop, we have Baitul Mal. Also, if the patients go through government hospitals, we do have facilitators to do that as well. But the foundation has been very active in the last 15 plus years.
Thank you for my information, but we in the public sector usually face problems, and yes, you have rightly mentioned there is social welfare department and Baitul Mal, but we don't all the time get assistance for them. And I think in Children's Hospital there's a better organized place because a proper department has been set up. Otherwise, it's being treated in the general medical pediatric wards, and we have selective patients, and now what we are doing is we are referring those patients to Children's Hospital so that they are better taken care of at a specialized facility, and they would get more facilitation, rather they are, as you have mentioned, closely knitted with the organizations and the society.
Bilkul, nahi, that is great, but I just want to throw it out to everyone that, we do have dedicated pediatric rheumatology clinics in our departments as well. And I think it would be good to sync pediatric care with rheumatology care as well, so that, we rotate the patients at least once every 6 months, because obviously there's so much we can learn from each other. And if they need to come to us, we do have support for treatment as well. Just putting it out there.
Thank you. I would like to thank you also here, because usually people, you have invited us on this forum for rheumatology. This is the first time, and I'm really indebted, because we've given us a chance, and there would be a better coordination and cooperation among the departments, and we would be in a better position to cooperate and help our patients.
Thank you so much. We look forward to that. That's the whole idea. We need to work together for our children. Laura?
Hi. I just wanted to say that this was a brilliant session. The speakers were all so wonderful, informative, clear. As a pediatric rheumatologist, I still learned some things, and so really well done to all the speakers, and congratulations.
Thank you.
Might I add, just on behalf of the broader PEDRIM community, I'm not sure to what extent the audience recognise how much Prof. Samara has contributed and the leadership that she's provided, and particularly the momentum that she has created in the Asia Pacific to progress the specialty, and her passion has been about access to paediatric rheumatology, and her leadership has been invaluable, and you should be very proud of that, of her as one of your compatriots, and we're just so privileged and grateful to have her leadership, and thank you, Prof.
Thank you so much for that. I'm blushing.
We definitely are. We are so proud of her. She's torchbearer of pediatric rheumatology in Pakistan, and she has mentored so many of us. With this, we conclude our second session.
It's okay. Thank you, Dr. Samara, for holding such an informative session, and I always firmly believe that collaboration and keeping in touch is the way forward for better care of our patients. And I'm happy that you are handling such a clinic where financial assistance and long-term morbidities and crippling disease can be actually managed, or at least given some assistance. So we'll keep referring to you. As far as that presentation where the mimicry or other disease manifestations were being ignored, this is a common challenge for all of us, especially in busy outpatient departments, where many a time rashes are being missed, which may indicate lupus, which may indicate sometimes this arthritis. And I can very vividly remember a patient which was case of acute leukemia 2 decades ago. And he was being given, assigned a diagnosis of some joint problem, and he was walking with a limping gait. And one of our very learned senior, he pointed out, why not to go for a peripheral picture? And let's see, he's not getting well. So this was a lot of blast in the peripheral picture, which clinched the diagnosis. So we always need to keep our eyes open and pay attention to all kind of rashes or signs which really are different, and we need to go from the history and at least basics so that we can make a proper diagnosis. Thank you very much.
Thank you.
I'm looking
Thank
forward
you.
for your collaboration.
Thank you, Professor Najaf.
Thank you very much, everyone, and especially the organizer for inviting us and the speakers. This was a very wonderful session. I have one question with Tashmi, that what is the importance of physiotherapy? Because he has mentioned all the medical or pharmacological treatment, and we usually, this is the lifelong disease. So what is the benefit of physiotherapy, and what should we advise to our kids?
So Tash, the question is, what is the role of physiotherapy when we are working with children? Unmute kare. Tash, you're muted.
Oh,
yeah, now
sorry.
we can hear you.
Reset again. So for the children, growth and development is very important. And kids at different age actually learn the motor skill, especially gross motor, differently. If they miss that period, the development may not be normal. So that's why we put the physical therapy, especially I have to stress enough that the one that has limitation of range of motion of the joint, those are the one. Does not even think about the limping one. Those are quite sure that you need to put. So on the exam, if the patient has limitation of range of motion, especially the limbs or the part of the joint that they require to do normal daily activity, you want to be as normal as possible. So physical therapy would help you. And kids, you need someone to guide them to do so. Okay, you cannot just like adult, oh, you do this at home. No, they need to have a kind of like a pediatric physical therapist or occupational therapist who does the play therapy with them and guide them, or actually play with them to do that in order to recover from the unused muscle atrophy or even the bone growth.
Thank you.
Physiotherapy. So the one that has the ability has to do it for sure. The one that does not have any limitation, you don't need to. I forgot to mention that. Yeah.
No, I think I know that Som did mention that she's not going into the details, or I think you did, of physical therapy, but of course it has to be an integral part of rehabilitating children. I think especially because they will not complain, they adapt themselves, they get used to it, and it is generally only a vigilant mother or older sibling or a teacher or somebody who sees that there's something awkward in the way the child is, using any part. So that's important for us as adult rheumatologists to know also, that kids will not complain many times and you have to be more vigilant. So yeah, thank you. Professor Fahim.
Thank you very much, madam. Thank you for inviting us. I would like to add in the talk of Dr. Somarat, although we think of the malignancy very often in the differential diagnosis of GIA, but when we see on the very few occasions, we also receive concert that particularly in the cases of systemic GIAs where skeletal manifestations are not very common, how often would you see the close differential of periodic fevers in cases of systemic, as an alternate diagnosis of systemic GIA?
So Som, the question is, in children who come with fever, rashes, joint pains, how often have you seen autoinflammatory or syndromes as opposed to systemic onset, or somebody who's been referred for systemic onset to you?
Okay, thank you. So the autoinflammatory disease is quite rare in Thailand. And the one that I diagnosed with autoinflammatory disease, there will be the history of like periodic fever, like every cycle, like fever, high-grade fever for every month. and they have the constitutional symptoms as well. Like I have one case with hyper-IgD syndrome. They present with a high-grade fever with arthritis, abdominal pain, and rash. And the rash is different from the seismic JAA. And in my country, the seismic JAA is quite often. Among the 7 subtypes of JAA, seismic JAA is the first that we found in my country, and follow with the ERA. So if the patients present with the salmon rash, with come and goes with the fever, and when it's gone, it's like completely gone, and patients usually have persistent fever. It's not like periodic fever. So that's why I think that the history will help me in the diagnosis of systemic JA. So everything about systemic JA first.
Okay, thank you so much.
Thank you.
Before I ask Dr. Samia, I would like to request Professor Nikhat, Professor Ahmed, Dr. Saira, Dr. Shabnam, Dr. Rafaqat, Dr. Shabir, Dr. Yasir. Please come. Nikhat, aap pehle. Please, Samia, we will be waiting for you.
I would say special thanks to Dr. Samaira and the organizers of this review course who invited us for this wonderful activity. And about the speakers, all the 3 speakers, their talks are really excellent. We learned a lot. And at the end, I listened about Arthritis Care Foundation is also looking after the kids. Inshallah, in near future, we have a better collaboration. And in reference to Khaja Saab's question, our Baitul Mal is really active. We are arranging biological agents as well as certain foundations, certain donors, they are giving us donation, and we are successfully giving these highly, actually expensive medications to the kids. Thank you so much once again.
Can I just, before I give it to Nikhat, thank each one of you. You know, it's such an honor for us, for you to have responded to an invitation. The point is, our kids need to get better. We cannot do that if we don't work together, if we have a small heart, we're not open-hearted with each other. It would be a shame, and I think I'm so happy that you're all over here. So, Professor Ahmed to join us, Dr. Amna Ahmed, please come to the stage. This is our wonderful faculty who works with us. I see some of my trainees here, Qasim, Arshad, Ans, Madiha somewhere, I think. So, Dr. Tausif, thank you so much for coming, and over to Nikhat, and this is good. Thank you all so very much. Okay.
Want to give a big hand to Sumaira, and Rebecca, I couldn't agree with you more. She really makes us proud, and I'm really proud of her. She stood up for children with arthritis, and I think it was a struggle, and there was no going back, and there is no going back. So, best wishes for future. Thank you so much. Thank you so much for coming here.
And we have flowers for all of us.
So, I think we can let you all go. Can I say thank you to... I know flowers, so then I just want to say thank you to...
Before we conclude, we would like to give a small token of appreciation to our worthy chair and panelists. I would like to call upon Dr. Samia Naz to receive hers.
I just want to say
Next, can I please request Professor Fahim Afzal to come forward? Professor Najaf, can you please come onto the stage and receive yours? Professor Iftikhar Ijaz, can you also please come onto the stage? And last but definitely not the least, Professor Khwaja Amjad Hussain. And we have one for Dr. Laura as well. Can you please come forward? With this, we conclude our second session. Thank you very much, ladies and gentlemen.
Thank you so much, everyone. Now we move on to the last session of this course. It is an interactive session for which I'll request our chair, Professor Muhammad Ahmad Saeed, and Dr. Ghulam Shabir to please come on the stage. They will be the chairs for this session. The first session is about P-galls and an extended rheumatological examination. And there is a video of P-galls. For an information about P-galls and the video, I'll request Dr. Laura Lewandowski to please come on the stage. We have a recorded video that we'll show.
Hello, everyone. We are about to introduce the PGAL session, and I just want to start by saying that there's been an incredible collaboration around this tool and app. So PGALs is a practical guide to the pediatric musculoskeletal exam, and it was developed by a team from PMM Online to be free and widely available. It's translated into multiple languages, and they've expanded from just a basic musculoskeletal exam to additional studies, case-based learning. There's just so much on the website for physicians, general practitioners, allied health professionals, nurses, so it's an amazing resource. And I'm hoping that we can get the video to launch so that we can show just a short introduction to PGALs today. We'll include a link to the website and the app and some resources to distribute to members of the course after.
This is a free online resource. It has fantastic links. A lot of people have done a lot of hard work for this, including Laura, Helen Foster, Chris Scott. These are the 3 people, top of my head, I can imagine. And press is working with them as well. So they've put in a lot of hard work, you know. Please use this.
This animation shows a step-by-step guide on how to complete the PGALS assessment. All resources for the PGALS assessment can be found on the Pediatric Musculoskeletal Matters website. Go to www.pmmonline.org. Observe the child in standing from top to toe. Note any asymmetry, swelling, deformities, rashes, altered foot position, and also look at the alignment of the spine. Ask the child to walk, then walk on their heels and on their tiptoes. Look at the child for any difficulties due to swelling, reduced range of movement, poor muscle strength, or poor coordination. Ask the child to hold their arms and hands out straight in front of them. Look for elbow, wrist, and finger extension. Ask the child to make a tight fist with their arms out in front of them, palms up. Look for the ability to supinate, and if the child's unable to make the fist, is this due to reduced range of movement, poor strength, or possibly pain? Ask the child to pinch the index finger and thumb together. Look at range of movement and functional grip. Ask the child to touch the tips of their fingers with their thumb. Look for swelling and reduced manual dexterity and coordination of the small joints of the fingers. Ask the child to hold their hands out with fingers splayed and squeeze their metacarpophalangeal joints with your fingers. Check for pain. Ask the child to place their hands in a prayer position, palm to palm, and then back to back, keeping their elbows horizontal, and look for any reduced range of movement at the wrists. Ask the child to reach their arms up in the air and look up to the sky. Again, look for any reduced range of movement or an inability to lift the arms against gravity. Ask the child to place both their hands behind their neck with their elbows back, and again check for range of movement or a weakness that may indicate an inability to move the arms against gravity. Ask the child to tip their ear towards their shoulder in both directions and look for any pain or reduced range of movement. Ask the child to place 3 of their own fingers in a stacked position into their mouth and look for any restriction in the TMJ opening. The child will need to be lying supine on the bed or plinth. Feel for any effusion in the knees, look for any swelling, and feel for heat. Ask the child to bend and straighten their knees one at a time. Check their active range of movement and look for any passive hyperextension. Passively bring the knee and hip to a 90-degree angle and check the external and internal rotation at the hip, looking for any pain or restriction in range of movement. In standing, ask the child to stand and bend forwards, reaching their hands towards their toes, keeping their legs straight. Look at the alignment of the spine, checking for any scoliosis or kyphosis. All resources for the PGALS assessment can be found on the Pediatric Musculoskeletal Matters website. Go to www.pmmonline.org.
Thank you so much. Now we move on to our session B, which is of interactive cases, and that would be done by... Yes, it's a 20-minute session, and there would be a presentation by Dr. Elizabeth Eng from Singapore. She's a senior consultant of pediatric rheumatology, National University Hospital, Singapore.
She's also the co-convener of the APLAR Pediatric Rheumatology SIG.
Good afternoon.
And she is the chair of webinar committees.
I am Elizabeth Ang, a pediatric rheumatologist in Singapore, and I have this privilege of taking the last session in this pediatric rheumatology review course. We're going to go through 2 cases. The first is a 10-year-old girl with fever and a rash. She had fevers for about a month at the time of presentation to the rheumatology clinic. She also reported a rash around her eyes that began around the same time as the fever, which spread throughout her body. It was slightly itchy but not painful. By the way, she also mentioned that she had a painful ulcer on the right side of her upper lip. In the first week of her illness, she was most bothered by the rash and given cetirizine for it. In the 3rd week, other measures for the rash included aqueous cream and hydrocortisone cream, and for the fever, she received ibuprofen and paracetamol. Here is a picture of the rash on her face. 2 discrete annular lesions around her eyes with a distinct border. On her upper lip, on the right side of the upper lip, is a hardly noticeable ulcer, which was slightly painful. The rash did spread to the rest of the body and can be seen in this picture with a close-up of the rash over the right shoulder as follows. Here's another close-up showing discrete annular or maybe arcuate lesions all over the body. The rash was also quite extensive on her back as follows, and was also present on her legs. She had some investigations done which revealed leukopenia with a white blood cell count of 2.2, a neutrophil count of 0.98, a lowish lymphocyte count of 1.06, anemia of 9.5 grams per deciliter, but a normal platelet count of 230. Her ESR was elevated at 57, as was her CRP at 36. Albumin was slightly low at 30 grams per liter, but she had a normal ALT and AST, a normal ALP, and a quite normal LDH. Her renal panel was unremarkable apart from the raised creatinine at 88 micromoles per liter, or 1 milligram per deciliter, higher than expected for her age and height and weight. The urine dipstick showed protein 1+ and nitrites positive. On her microscopy, she had white blood cells of 10 per high power field, red blood cells 2 per high power field, and bacteria seen. The urine protein creatinine ratio was slightly elevated at 0.08 grams per millimole. We take 0.02 and less as normal. Other investigations revealed that she had normal complements, a normal or negative anti-double-stranded DNA, but a highly positive anti-nuclear antibody at more than 1 to 640. Her urine culture eventually came back growing E. coli. Is this SLE? This is a 10-year-old girl with fever, a widespread rash, leukopenia, lymphopenia, anemia, proteinuria, elevated creatinine, hypoalbuminemia, elevated ESR and CRP, and a positive ANA. But she had normal complements and negative anti-double-stranded DNA. Because the diagnosis was in question, we looked for more evidence or clues to lupus. And this is what we got. She had a positive direct Coombs test, which speaks to autoimmune hemolytic anemia. Her coagulation profile was negative, but she had a positive lupus anticoagulant and a raised anti-beta-2 glycoprotein IgG. Her anti-ENA panel came back with a positive RNP, but the rest was negative. Looking at the SLE classification criteria that most of the senior doctors are most familiar with, she seemed to tick the boxes for a hematologic disorder, an immunologic disorder by way of positive antiphospholipid antibodies, and a positive ANA. But using the same criteria, she did not get 4 out of 11. Her rash was not typical of the malar or discoid rash familiar to many of us, nor did she seem to have significant proteinuria, although her creatinine was elevated. What about looking at the 2012 SLIC classification criteria, which is supposed to be more sensitive? She ticked the boxes for hematologic disease and immunologic abnormality. The renal disorder was in question. And of course, what was this strange rash? On to the 2019 ACR-EULAR criteria, again, she ticked the boxes for autoimmune hemolysis, leukopenia, and an unexplained fever. That would give her a total of 9 points. But what about the renal disease? And was she satisfying criteria for acute cutaneous lupus or subacute cutaneous lupus? Let's look at her rash again. Here we see the rash, which is fairly widespread, present on both photoexposed and non-exposed areas. Because the cutaneous manifestations of lupus are prominent, they form part of the classification criteria. Look specifically at the SLIC 2012 or the EULAR 2019 mucocutaneous items, and we have here the possibilities. Which one is this 10-year-old girl? I believe Dr. Satish has given a wonderful talk on the cutaneous manifestations of lupus, and I will not be going into the detail of that. But as a small revision, the 3 specific cutaneous lesions of lupus include, firstly, acute cutaneous lupus erythematosus, most commonly known to us as the butterfly or malar rash. Secondly, the subacute cutaneous lupus erythematosus. And thirdly, chronic cutaneous lupus erythematosus. The most common type of the CCLE would be the discoid rash. Then, of course, there are a host of non-specific lesions. In this table, I compare how children differ from adults in the various presentations of the 3 lupus-specific rashes. With regard to the malar rash, also known as ACLE, this has the highest association of all lupus-specific rashes for SLE. How about for the subacute cutaneous lupus erythematosus? In adults, 1/3 of these rashes seem to be related to medication, and the risk of progression to SLE is 20 to 40%, but the SLE in such cases are usually mild. For children with SCLE, there is a lower incidence of drug-induced SCLE, and compared to adults, a higher risk for SLE. This SCLE in children also tends to be associated with C2 or C4 deficiency. Finally, for discoid lupus, the most common subtype of CCLE, in children the risk to SLE is uncertain, perhaps 30% in some studies, and in these patients the SLE phenotype is unknown, whereas in adults the risk for SLE is better known at 25 to 40%, and the systemic disease in these patients tends to be mild. Of the 3 lupus-specific cutaneous manifestations, the SCLE subtype is the least common. The SCLE type of rash can be further subdivided into an annular subtype and a papulosquamous subtype. Since this was uncommon, I had to look further as to what SCLE looks like in children, and we have pictures from case reports such as these, which made me think of the patient in front of me. We had to get the diagnosis for sure. The patient underwent a skin biopsy which showed interface vascular change with perivascular and periadnexal lymphohistiocytic infiltrate extending from the superficial to mid-dermis. She also had a positive direct immunofluorescence studies. The SCLE type of rash tends to penetrate to the mid-dermis, whereas the discoid or CCLE type of rash penetrates deeper to the deeper dermis. Of course, the malar or ACLE type of rash tends to be more superficial on biopsy. So we got the diagnosis of SCLE. With the confirmation of SCLE on skin biopsy, we can say that this girl ticked another box according to the 2012 SLIC or the 2019 EULAR classification criteria. Altogether, she did indeed fulfill criteria for SLE, even if she was unusual in that she had such normal complements and a negative anti-double-stranded DNA. With that in mind, did she still need a renal biopsy? And I will argue that she did. This leads us to our first question. What did her renal biopsy show? Class 3 lupus nephritis, Class 4 lupus nephritis, Class 5 or membranous lupus nephritis, tubulointerstitial nephritis, or lupus podocytopathy? Make your best guess, keep it in mind, and I'll see you again at the live Q&A with the answers. Even though you may not have the answer for what her renal biopsy shows right now, there are 3 learning points I'd like to share from this case. Firstly, classification criteria are not diagnostic criteria. Our patient did not tick the boxes according to the 1997 ACR criteria. However, it's important to note that a patient who does not satisfy the classification criteria may still have the diagnosis of SLE, like in this girl. Secondly, there are other rashes in SLE besides the butterfly or malar rash, also known as ACLE. I hope that after today you will remember what SCLE can look like, and of course, you know the CCLE or discoid lupus. Thirdly, renal biopsy is essential in patients with SLE or suspected SLE and urine abnormalities, and this is for therapeutic decision-making as well as prognostication. Case 2 is a 15-year-old boy who is known to have systemic juvenile idiopathic arthritis, SJIA, and now presents with a fever. He is on medication for his SJIA, namely prednisolone 5 milligrams daily and injection methotrexate 20 milligrams weekly. He came to the clinic because he has had a fever for the last 3 days, and this is associated with a sore throat and odynophagia. He reports that he has had daily spikes of fever up to 39 degrees, chills and rigors, and sweating when the fever comes down. He doesn't have any cough, rhinorrhea, anosmia, headache, myalgias, arthralgias, or rash. He has had no sick contact or travel. His vaccinations have been up to date, and this was before COVID, so it really wasn't a consideration at that time. Here's his medical history. His SJIA was diagnosed 2 years before when he presented with a very prolonged fever, a rash, and weight loss. His PET scan eventually revealed lymphadenopathy, and on exclusion of other sinister causes of a POO, he was diagnosed with SJIA. His arthritis came only 4 months after the diagnosis of SJIA. Since that diagnosis, he has had intermittent flares that usually present with fever, and he was treated with temporary increases in oral prednisolone. There were discussions on using steroid-sparing medication, but the family was not very keen at that time, and since he seemed to be well on prednisolone 5 milligrams and injection methotrexate, he was kept on these medications. His last flare prior to this fever was 2 to 3 months ago, and at that time he had a fever and a right knee arthritis. This time, here is his physical exam. At the time of recording, he had no fever, and his vital signs were normal. His weight and height were as follows. He was alert, comfortable, and non-toxic. He had no rash, pallor, or jaundice. His pharynx was normal. He had no ulcers. He had no lymphadenopathy. The heart, lung, and abdominal exams were all normal. He had reduced left elbow flexion and mild elbow tenderness, but the rest of the joint exam was normal. Here are his investigations at the time. He had a markedly elevated white blood cell count of 30.6, which was predominantly neutrophils. His hemoglobin and platelets were normal. His ESR was 42, but his CRP was very high at 335 milligrams per liter. His ferritin was also very high at over 2,000 micrograms per liter, and his procalcitonin was very high at 9 micrograms per liter. The normal is less than 0.1. For the concerns of sepsis, blood and urine cultures were sent. His LFT on the right-hand side, as well as his renal panel, were normal. Of course, he was treated as for sepsis with broad-spectrum antibiotics, IV ceftriaxone. His risk for sepsis was even higher given that he has been on steroids and methotrexate for the last few years. However, 12 hours after admission, he developed one episode of non-bilious, non-bloody vomiting with diffuse abdominal pain. At this time, he was most notably hypotensive with a blood pressure of 73/34, tachycardic with a heart rate of 140. Even though he was hypotensive, he actually appeared quite well and had his IV drip ongoing, and he was well perfused. His physical exam was quite unremarkable. He was resuscitated with IV normal saline. His antibiotics were escalated to IV meropenem. ECG done was unremarkable. Blood tests were repeated and showed no evidence of macrophage activation syndrome. He needed peripheral dopamine at 5 micrograms per kilo per minute with improvement in BP, and his hydrocortisone or steroid doses were increased during this acute deterioration. After this, his fever settled. His blood and urine cultures returned sterile, and so the thought at that time was for a culture-negative sepsis with seeming response to antibiotics. 5 days after admission, which is about 2 to 3 days after this acute hypotensive episode, he developed acute onset retrosternal chest pain without radiation. This pain was severe, worse with breathing and movement, and he felt much better once he sat up in bed. He did not have dyspnea or orthopnea. This chest pain was associated with return of the fever, but the rest of the vital signs were normal. The physical exam was notable for a pericardial rub. Here was his ECG done at the time of the chest pain. And next, I'm going to show you his X-ray, as well as his cardiac enzymes. Now for the question. What is your diagnosis for this 15-year-old boy at this point of time? Did he have myocardial strain, myocarditis, pericarditis, myopericarditis, or a pericardial effusion? And with that in mind, the next question. How would you treat him? High dose, non-steroidal anti-inflammatory drugs, higher dose steroids, anakinra, which is an anti-IL-1, assuming that this is available, tocilizumab, which is an anti-IL-6, or a pericardial tap. We'll discuss the answers when we meet. I want to highlight some learning points from this patient. This is a patient that may be very similar to patients that you see in your clinic, on a little bit of steroids, on some methotrexate. He is considered immunocompromised, and fever in an immunocompromised host must always make us concerned for infection. Indeed, this boy had a lot of features concerning for that, a very elevated CRP and procalcitonin. At the same time, be ready to treat these patients, sometimes concomitantly, for complications of the rheumatologic disease in question. We're going to move into a time for some answers, and I'd love to hear from you. See you soon.
Is Elizabeth online?
Elizabeth is online.
She's going to be online to answer the questions. Yeah. Hello. Yes. Hi.
Hi, can you hear me?
Oh, Liz, that was a fantastic presentation. Really enjoyed it. So I want to introduce Professor Ahmed Said to you. He is my senior colleague. No.
So, Liz, I actually have an honor of being Professor Somaira's first trainee in pediatric rheumatology. I must admit this because I was the second fellow to join Professor Nighat. So my first introduction to pediatric rheumatology was when I joined. She already had started gathering data on pattern of JIA seen in the daily clinical practice. And I remember that there was like pile of 100 cases which he handed over to me. So now compile it and start writing a manuscript. So this is 2004. And that publication came in 2005, so we were able to publish it. So this was the start, a humble start of actually pediatric rheumatology, and that was the first publication coming from our department. It is really pleasure being actually like hosting our second pediatric rheumatology course. Both cases, they are excellent, brilliantly presented. So we were wondering, we actually had a third case we wanted to bring in and present. Can we have that case? One of our fellows, Dr. Ambreen Arshad, she's a first year fellow. Yes, iske kar lete sawal ya isko. Okay. Okay. So if you people have any questions, so which are directed to her, so we can ask them first, and then we can proceed. Yeah. Any questions from the audience?
And any answers to her questions?
Yeah. So. To me, I believe your second case, which you presented, is very much similar to ours. And this is what exactly, so I am not going to come up with the answer, but rather would ask you what is probably the best possible option. We, unluckily, we don't have access to anakinra. We do have on prescription availability, but not like available widely over here and being used. We are left actually with treating tocilizumab such patients. And I am wondering that your patient seems to have just myocardial involvement in a process of a very active systemic GI. So what the answer, I believe, should be tocilizumab in that case. What do you think, Liz?
Well, in this patient's case, the 15-year-old boy with systemic JIA, who you rightly said just had really poorly controlled systemic disease, and he had a pericarditis with some myocarditis, which was the cause of his severe hypotension. Because we have access to anakinra, we gave that to him. It took a while. The family has always been very against other medicines, but it was like magic. We gave it. He had been in the ward for 2 days with severe pain, unable to sleep. Within minutes of getting the anakinra, he had a smile of relief and he leaned back. The reason for the choice of anakinra was manifold. Firstly, I think even in patients who have idiopathic recurrent pericarditis, IL-1 inhibition seems to work very well. The other thing that made it easy for us to give it, of course, it's easily available where I work, and that's always very helpful. And I feel very safe using anakinra even when there's a question of sepsis. I suppose the question is, if anakinra isn't available, what recourse or what are the possibilities? I think it is still very reasonable to try and start high-dose NSAIDs, and I know our cardiologists have a preference for indomethacin over ibuprofen or diclofenac. I have not had to use tocilizumab in these cases, although I can see why it could work, because the overall setting is in a child with severe SJIA. I'd love to hear what experience you had when you used tocilizumab in your child.
So we just actually restarted her on tocilizumab. Actually, she had this episode of shortness of breath, orthopnea, and was admitted with lobar pneumonia, and then she had ejection fraction of around 25%, and we were worrying whether it is a viral myocarditis or with viral pneumonia, or is it really primarily her disease, or was she having this beforehand and we were not totally aware of it, because this might be a possibility that she was already having myocardial involvement, and that really went undiagnosed and we were not able to pick up. that one. So she has been restarted on tocilizumab sub-Q because generally this is what we are doing. So every 3 weeks now she's getting it. She's 15, but she looks like someone who is just 7-year-old. She's growth retardation because of long-standing use of DMARDs and poor access to biologics over a period of 13 years of her illness. She started having it when she was 2-year-old, 3-year-old. So it's a long disease, and that from that standpoint. But our worry was also in that case was that she might have developed premature atherosclerosis. But luckily, the pediatric cardiologist, we consulted him, and we came up finally that because there was no segmental wall motion abnormality, so this is possibly involvement per se because of the disease.
Do you use subcut Actemra?
Yeah, so do you people use, if you have to use tocilizumab in patients with systemic GI, so do you use anakinra, which is like an infusion form, or sub-Q, subcutaneous?
We use both in our patients with systemic JIA for longer term where joints may be more prominent. I think sub-Q tocilizumab seems to be more acceptable to the patients. For patients who present with predominant systemic symptoms, anakinra would be my choice, although it is hard for a lot of these patients to take it regularly. I'll say that in this boy, we initiated him on anakinra, and right now he's actually on tocilizumab and doing very well.
Thank you, Liz. Thank you for your time. So if we don't have any more questions, so then we can end our session over here. So we are lagging a little behind time as well. So second case, first case, are there any questions? Ji, please.
Yeah.
So anyone who wants to answer the questions which were posted by Dr.
I feel like I'm holding you all up from lunch, and I really admire those who stuck behind. I'm going to give you the answer for the 10-year-old girl with the subacute cutaneous lupus, proteinuria, and elevated creatinine. Her renal biopsy came back and was a surprise to me as well as the pediatric nephrologist. She came back with a biopsy showing tubulointerstitial nephritis. Not something we would have guessed, is associated with lupus, but ultimately the nephrologist felt that this might have been drug-induced. Whatever it was, thankfully, the treatment of tubulointerstitial nephritis also includes immunosuppression, but I think it was just an interesting, unexpected result. Thank you very much.
Thank you. Thank you. Thank you so much.
I think we're closing this.
Thank you. We are closing the course.
Yes, thank you.
We thank everyone for participating and attending, and we thank all our chairs and panelists and the international speakers, and we are especially thankful to APLAR for endorsing this course. Thank you. So now I request everyone to head towards the lunch area, and we should come back at 2:45. You have 45 minutes, and then we'll be starting with our nail fold capillaroscopy workshop. We'll send you a picture of your lunch. Thank you. lunch